and every byway.
So, guys, whether you know it or not, this course is pretty much over.
Aww.
Yeah, that's right. That's the right response. So listen up. This is your last day of any new lecture didactic information. That's right. This is it. We got to teach you a few more skills tomorrow, and next week is all review. Now, listen carefully to the words coming out of my mouth, because your course could depend on this. Did you hear what I just said?
Yes.
All right, so, as a reminder to you, you will need an average score of an 80% or greater to get your ticket to the final. Oh yeah, now it's funny. Right? So, guys, your last quiz will be on Monday. Tomorrow, I will be handing you out individually. Well, Alexis will be handing you out individually, right? Your grades. All your grades on all your quizzes thus far. That will be 11 quizzes. It will be the only time we give you your grades. So, you better keep your score on Monday's quiz. Now, listen carefully so you understand this. For those of you who have to retake quizzes to raise your average so that you get your ticket to the final, there is a strategy to it. Listen carefully, because next week is all review. No. Wouldn't it be really good to get a review on information you needed to take a retake on?
Yes.
All right, so here's how it works. You might want to write this down. Sing if you know the words. Monday is your full medical emergencies review. That will include human body, all of your medical emergencies. Did you just bristle at human body? If you don't know human body by now, we got a problem.
No, I didn't put his name.
Human body, all of your medical emergencies, and it will include OB, your obstetrical portion of your pediatrics we did the other night. That will be Monday. Tuesday is your big trauma review. That will be all your traumatic injuries. That will include environmental and pediatrics. So here we go, guys. Listen carefully. If you do not have your average of an 80% or greater on all 12 quizzes by the beginning of class on Wednesday, your program will be over. You will not be coming here Thursday to take the written exam. So, you have a very small window in which you can retake quizzes. Those of you who forgot, you can retake 5 out of your 12 quizzes one time. You get one retake on each. All right? So, the best day to retake quizzes is actually Tuesday. Number one, Tuesday, you will not be disturbed by any other class. Why? Because tomorrow we start a new morning class, so Monday and Wednesday, you won't be in this classroom retaking quizzes because we'll be lecturing. You can still take quizzes, right? But you won't be in here doing it. So Tuesday is an excellent day, especially since most of you have to take multiple retakes on medical emergencies. And what I told you about medical, compared to trauma, pretty what?
Hard.
So weird. So, excellent time. Because most of you, really all of you, will probably have to take more than one quiz. Yes, because most of you don't really understand the math. It is your biggest downfall. So I'm going to explain the math to you. Try to understand this, right? Let's say on all 12 quizzes, you have, say, a 75% average on all 12 quizzes. Definitely doable with 5 retakes. However, if you think you're going to come in here and take one quiz and that's going to do it for you, yeah, I have news for you. It's not. Why? Because of the math. So listen carefully. If you have a 75 average in class and you retake a quiz, and you raise that quiz score by 20 points, you made a 60, an 80. That's great. The problem is it only raises your overall average by 1.3. Did you hear what I said? Because it's divided by 12. That means you just made a 75, a 76.3, which is nowhere near where you need to be to get your ticket to the final. Which means most of you have to take multiple quizzes. Even if you had a 78 in class, that would not be enough. You get that now? Does everybody understand the math? Right? Because it drives us crazy when you think you can come in here, you do not retake your quizzes. You are not prepared. You come in, and you think one quiz is going to do it for you. Oh, and by the way, don't speculate what you're going to get on a retake. Because guess what? If you don't get a higher score, it doesn't raise your average at all. And before you ask, I'm going to give you the answer. No, you don't get the lowest score. You always get the highest score. So in case you blow it again, you don't get the lowest score. And that is how your retake works. So now you know. Now, it's a good idea to spread them out a little bit, right? Do not think by any measure or stretch of the imagination that you're going to come in here and try to take 5 quizzes on Wednesday. That ain't going to happen. Did you hear what I said?
Yes.
Don't do that. Number 1, right, we have found the optimal amount of quizzes that you can retake before your brain explodes is 3. Number 2, it's going to take forever. Keep in mind, it's going to take you probably anywhere from 40 to 45 minutes to retake a quiz on each of them. So do the math. Our office hours, you can come in by 10:30 to about, when the class starts. But you got to be done. So Tuesday is a good day. Why? Because there's nobody else here, right? That's teaching. Wednesday, you guys can come in and retake quizzes, but you're going to have to be in the side rooms because we're going to be teaching in the class. Get it? Got it. Any questions about retakes? Ooh, one other thing, my A personalities, because I know you're out there. If you have an 80% or greater on all 12 quizzes, no, you cannot retake quizzes. Knew what you were thinking. I knew it. Number 1, right? We have enough quizzes that we're going to have to grade. Thank you very much. Number 2, really just look at the quiz scores you got the lowest on and study that material, because that's where you're weak. Get it?
Yeah.
Good. Any questions about retakes on quizzes? Okay, guys. Yes, sir.
So if I have a 97, I can't make it a 98.
Can you retake a quiz if you're passed? No. You'd be surprised. I just want to retake that. Wait, you've got like an 89% in class. I just want to freaking A personality. I know.
I'm not an A student.
I didn't say A student. I said A personality. Snap.
Got you there.
All right. So, guys, any other questions? All right, guys. Pretty exciting stuff today, guys. I told you this class is going to be over just like that. And you're going to be like, what happened? You'll be like, what happened was. All right, guys. So, my question to you, as it is every day, is... Are you ready? Are you ready?
Yes.
You missed me yesterday, huh? You're like, what happened? Where's the energy level in here? All right, guys. The one, the only, Mr. Vincent Conte. Woo! And Furman. Woo! The giant fuzzy dog.
Alrighty, so.
I know.
He wants a banana. Oh, sorry.
He's not big on bananas.
No.
No. He was like, well, maybe. Maybe
It's been a while since I've
that Oreo thing you have on the table. He does have a sweet tooth, guys. He does. Oh, yeah. Pancakes.
Hey.
Oh.
I'm right there.
Pancakes. Lemon cake. Loves ice cream, but you're not supposed to give dogs.
You give him pup ice cream.
Yeah, pup ice cream. But he knows the difference, you know. He totally does. You know the difference, don't you?
Alright, so enough about Bourbon's diet. We'll go ahead and move on to our lecture for tonight. So, we're going to go ahead and cover our pretty much pickup stuff. So, just kind of continuing from the first stuff we talked about at the very beginning of class, right, as far as the ambulance operations stuff. Okay, so again, this is going to be one of the 5 categories of the National Registry, and it's the one you guys do the least on, well on, because you're like, it's ambulance ops. How hard can it be? Well, when it comes to triage, just like burns and diabetes, you guys what? Right. So therefore, it makes it very difficult. Okay. So we're going to start off with ICS. Okay. So incident command system. Right. All the FEMA courses that again you guys are supposed to know since you took the exam. We're also going to be covering our day-to-day kind of behind-the-scenes stuff. Right. With ambulance operations. Yay. Right. Extrication. Yay. Okay. As well as lifting and moving patients. All right. So there's not going to be much in terms of like medical stuff that we got to hit. It's just more just crap that we have to hit. So, as far as Incident Command System, or ICS, okay, it's designed to pretty much utilize as many resources as we possibly can, right, when it comes to large-scale events. Okay, this is all set up by the federal government, so we know how efficient that's going to run, right? But they're the ones who set it up, right, to pretty much reduce things like freelancing and overlapping and waste of resources and personnel and all that kind of stuff. Okay, what's up?
No superheroes, no freelancing?
No.
Can't just you watch The Boys. Sarah.
Actually, I gotta watch the new season.
It's good. Oh, the new
Yeah.
season.
So, maybe I'll do that on my trip. We'll see. So, as far as span of control, okay, it's going to be delegating different roles and responsibilities. So, we're going to have a breakdown of the incident command system that we're going to be hitting in just a bit. There it is. So, we have the IC, which will be the incident commander. Okay, so the IC, or the incident commander, is pretty much the head honcho on that scene. Okay, now one thing you have to understand with the incident command system is it is scalable. Okay, so the incident command system is scalable, which means I don't have to use every single one of these branches and all that kind of stuff. It just depends on the size of the incident and the event. Okay, now with the incident command system being scalable, the incident commander is not always the exact same individual throughout the entire event. Okay, so the incident commander title can switch from one person to the next person to the next person to the next person to the next person, okay, based on their level of experience, right, or expertise in that specific criteria. Right, now usually it's going to be the person who's got the most experience who's going to be incident commander. So let's say myself and my paramedic partner, we roll up on a school bus crash. Right, between an EMT and a paramedic, who's going to be incident commander? Paramedic. Okay, and until fire rolls up, where you now have a captain show up, who's now going to be incident commander?
Firefighter.
All right, the captain. Not just the regular firefighter, the captain himself. Right, and let's say chief shows up. Who's going to be the IC? Chief, and so on and so forth. Okay, and then we have other people who have degrees and stuff like that and this kind of crap. I don't know why they do that, but they would start becoming the incident commander. Now, let's say this situation becomes a hazmat scenario. Okay, now whoever's got most training in hazmat, they can now become the incident commander since they've got the most resources and training to actually manage that scene appropriately. Okay, so the title can be handed off from one person to the next. It's not always the same individual from start to finish. Okay, the incident command post is basically headquarters where this pretty much is going to be set up at. Okay, we have different officers as well. So we have the safety officer, who is responsible for what? Safety. Okay, so their primary job is looking out for safety for not only personnel on scene, but also patients and any bystanders that may be present. Okay, we have the PIO, which is the Public Information Officer. Okay, so the PIO is the Public Information Officer. And they're the ones who are going to be talking to the media, right, about the event itself. So if watch the news and you see some big event happening, the person who's talking on the camera is the Public Information Officer. It's not always the incident commander. Okay, so they delegate one person, hey, you're going to be standing in front of the cameras. Right, and we have the liaison, who's essentially going to be a runner between all the different sections. Okay, now one reason why we have to implement this stuff is because of miscommunication and a communication breakdown. Right? Well, essentially what happened with these large-scale events is it'd be like a game of telephone, where one person says one thing, and it relays from one person to next person, next person, next person, next person, and by the time it gets to who it actually needs to get to, is it the same message? No. Okay, so the liaison's job is to go from the incident commander and talk to, let's say, logistics directly, right, limiting how many people have that message has to go through. All right, so it's a lot more direct, right, without having all that kind of stuff occur. Now, with the different divisions, we have operations, planning, logistics, and finance. We are going to operate in operations, specifically under the medical branch.
Oh, I thought it would be funny.
No. All right. So, okay, we're going to be operating under operations under the medical branch with the 3 T's: treatment, triage, and transport. Okay, so we're going to go and operate under the 3 T's: triage, treatment, and transport. Now, we may be working side to side with rescue, doing extrication and hazmat. Okay, and like I said, we'll be talking about hazmat, what their responsibilities are, and what they do later on in this chapter. Okay, so when it comes to the incident commander, is it always the same individual from start to finish?
No.
No. Okay, they're going to wear a vest that says incident commander. All right, and they'll literally take it off and pass it to the next person. Like, all right, here you go. You're now the IC. All right, and again, this vest will go from person to person to person to person to person as needed based on experience. You will kill so many people, sir. Okay, so we can go ahead and switch it over, right, to different people as needed. Right, and it can switch back and forth. Okay, we have, some type of issue with large number of patients. All right, they're going to take over. Oh crap, there's a hazmat situation. All right, you're now taking over. All right, and then we'll bring it back. Okay, so we can alternate back and forth between certain people. As far as the public information officer, again, they are the ones who will be talking to the media about the event. All right, liaison is just going to be a runner who's going to be sending messages back and forth from different divisions. All right, then we have the safety officer who is responsible for
Safety.
Responsible for
Safety.
Safety. Okay, and any order that is given in regards to safety, okay, even if it contradicts orders given from the incident commander, who do we listen to?
Safety.
The safety officer. Okay, so if that safety officer who's going to pretty much be boots on the ground looking at the scene, all right, let's say the incident commander sends a squad of firefighters into the building, and the incident commander or the safety officer is like, wait, no, that doesn't look safe. You guys are holding back. Okay, can they disobey that order?
No.
No. Can they disobey the incident commander's order?
Yes.
Yes, because it's an issue regarding safety. Right? So, obviously safety is number one, so we want to listen to that safety officer. Other divisions, we got finance, obviously responsible for dealing with the money aspect of it. Okay, so they're just going to be taking a tally of stuff. That way, after the incident's all done, then they can go back and start, providing reimbursement for different ambulance companies, for time, things like that. All right, supplies are used. Okay, so those are all those pencil pushers. All right, who are just going to be there. With logistics, they're going to be gathering things and supplies for us. All right, so they may be the ones calling out to activate those push packs and be like, hey, we got 1,200 patients here. All right, we're going to need, food, going to need tents, going to need all this kind of stuff. right? And they can start ordering that and getting that stuff there. As far as operations, they're pretty much going to be setting up what the plan of action is. Sounds confusing with planning, but planning is really more about accountability of personnel and problem solving if anything arises. Okay, so operations is just pretty much going to be the ones supervising everybody to make sure everything's going as planned. With planning, it's like, all right, if we have this issue, okay, I need to call for certain extrication equipment. Planning is going to talk to logistics to get that stuff coordinated. And then logistics goes later on and be like, hey, finance, pay us, right, or pay them, however that's going to work. All right, when talking, okay, if possible, use face-to-face communication. Okay, and try to talk directly to the person that you need to talk to. Hence why we have that liaison, right? Who is just going to be the runner between the incident commander and anybody else? Okay, we can obviously use radio equipment if needed. And when you are talking over the radio, make sure you're always using plain English, just like we would in a regular ambulance call. Okay, we don't use 10 codes or anything like that, because with an incident command system like this, where we have large agencies, multiple agencies that are working together, okay, they have their own different codes that mean their own different thing. Right, so for example, 10-4 is kind of universal for copy, right? We may have 10-8, right, which for one ambulance service means that they're going on scene, whereas 10-8 for another ambulance service means take lunch, right? So it depends on the different agencies. So you just say, hey, we arrived on scene, or hey, we're taking lunch, right? Instead of using whatever your specific 10 code is, right? There's always going to be backups and plan, which are the courses that you guys all took and all got certified in. Okay, that way if there is some type of communication breakdown, we all just pretty much default to those offline protocol.
Yeah.
Yeah, of course. All right, so when it comes to mobilizing, if we're not on scene when it happens, kind of like we talked about yesterday, okay, we are going to get sent to the event. All right, now with the incident command system, okay, again, they're trying to minimize freelancing and waste of resources. So what used to happen before this is you'd show up and you just do whatever you feel you had to do. Right? So just do whatever you feel you have to do, and we'd have 20 other people that are trying to do the same thing. Right? No, it didn't work. So with the incident command system, okay, they're going to set up a staging area, and that's where we report. Okay, so let's say they have, a park, right? That's their designated staging area. So when we get dispatched, they're going to say, hey, go to this park and report staging. So we go, and we go, okay, we're here. What do you want us to do? Okay, and the staging supervisor and or the incident commander, whoever's there on scene, okay, they're going to say, you know what, you guys are going to go start transporting patients, so you guys can start parking over there. Or you guys are going to go start triaging, so start making your way over that way. Or you guys just hang out. Someone's going to be coming off shift in about half an hour, and you're going to take their spot at doing whatever. Okay, so we go to staging, and we await our orders until we're authorized to go in. Right, now when we are staging, okay, we want to make sure we are in a safe place that is uphill, upwind, or upstream of the actual event itself. Okay, now if we are on scene when it occurs, we want to set that staging area in an area that is uphill, upwind, or upstream of the event. Okay, so we want to go ahead and make sure that we are set up, right, in a safe place. So that way when other people start coming in and start staging, they're not going to be exposed and worry about contamination. Okay, we also are going to check in because at that staging area, okay, they're going to take down our information to make sure the amount of people that are going in scene, right, are going to be coming off scene as well. All right, so let's say, okay, you guys are going to be out there for 8 hours. Make sure you guys come check back when you guys are done. All right, that way they can say, okay, this crew came back, cool. Or, oh crap, this crew hasn't come back, and now they got to go look for us. Okay, so it's all about accountability of personnel. All right, they can start shutting down areas as well as needed. So once all patients have been triaged, do we need any more triaging to be done? No. Okay, so you guys have been triaging for the last 4 hours. You guys are good. You guys can take a break. You guys just got here 20 minutes ago. You guys are going to go over a treatment area and start doing that. Okay, so they'll start rearranging resources as needed. Okay, so again, the whole incident command system is scalable depending on the issues that's at hand. So here we are in triage, treatment, and transport. Okay, that is where we are going to function as the EMTs. Now, if we have cross-training in other areas, we may be called to work in those areas as well. Right, so for example, with urban EMS, right, firefighters, okay, they're EMTs. They may be paramedics depending on their level of training. They're obviously fire. They may be hazmat. They may be extrication. Okay, so they can be put in different places, whereas us, we're stuck here. All right, now as far as triage, that's where we go and start sorting patients out based on the severity of their condition. Okay, so when we're triaging patients, we're sorting them out based on the severity of their condition. And like we talked about way back in patient assessment, does the patient assessment change in triage?
Yeah.
Yeah.
Oh, it does.
It does. Okay, we even touched a little bit on that on pediatrics. Okay, the triage assessment is totally different compared to your standard patient assessment. Okay, and that's why we save it to the very end, so you guys can master your basic assessment before we go say, hey, remember all that? Yeah, screw all that. Here's what we actually do. Right, because it's not the same assessment. Treatment is pretty much the same. Okay, we are going to move these patients to a treatment area where we provide any type of stabilizing treatments that are needed, and then we go and transport to different hospitals and facilities. All right, so we'll be going over our different divisions, what things are going to be going on while we're there, right? What our responsibilities are with this stuff. So we have a triage supervisor. So the triage supervisor is pretty much responsible for us triaging patients correctly. Okay, because we don't just go and start black tagging everybody just because they're there. Okay, we have to make sure we're triaging them properly. And again, when it comes to triage, you guys what?
Suck.
You guys what?
Suck.
You guys what?
Suck.
Right, and it's not that difficult. Okay, triage is just an algorithm. That's all it is. Okay, do they meet this criteria or do they not? All right, so we have to make sure we are triaging patients appropriately. Okay, and then we have the treatment supervisor, who's just going to oversee any treatments. So most treatments are done just to stabilize patients. All right, again, we're not going to have all the available resources we may need. Okay, it's just to perform any type of stabilizing treatments. And then we have the transport supervisor. I'll get to in just a second. Okay, but they're obviously responsible for overseeing transport. Okay, and those are going to be our direct supervisors. All right, so as far as delegation of supervisor roles with these different things, it's usually the most experienced person in that specific category. Right, so of all the EMTs who are doing triage, okay, they've got the most experience with it, right, or just longest time, so therefore they're going to be the supervisor. All right, same thing for treatment. Okay, with this, doctors may be on scene as well. Okay, and they can potentially expand our scope of practice within reason. Okay, so the stuff we talked about yesterday, right, even though we can't do most of that here in LA, even though we trained it to you, right, and it's in the national scope, medical doctor, right, can say, hey, you know what, for the time being, do you know how to start, do you know how to start a tube? All right, do that kind of stuff? I kind of remember from school. Okay, well, I'll walk you through it, but for right now, you can go and do that if needed. Okay, so they can temporarily expand our scope. But, they're not going to be like, hey, can you do a needle corticothyrodomy? No? No. Okay.
YouTube video?
Yeah, no.
YouTube video it.
Okay. So, right, within reason, they might be able to expand our scope. Okay. When it comes to the transportation supervisor, okay, again, they're responsible for transporting patients to the proper hospitals. So their job is probably the most stressful out of all of them because they have to manage where all the patients are going, which means they have to be in contact with all the different hospitals in the region and be like, hey, Long Beach Memorial, how many beds do you guys have available? Since you guys are level 2 trauma center, I'm going to go and keep you guys in reserve for our major trauma patients. Right? We're going to contact another hospital further down the road. Hey, how many beds do you guys have? All right, cool. I'm going to be sending my stable patients out to you guys since they're a little bit longer or a little bit further away. Right? So they have to go ahead and contact all the different hospitals, right, and see, okay, this hospital has 5 beds, right? But because it's a specialty center, I want to keep those beds open in case patients meet that criteria. Right? Or this hospital, right, is 45 minutes down the road, but they got a bunch of beds that are open. I'm going to go and take all my green tag patients, all my stable patients, send them all the way out there since they can survive transport. This hospital right around the corner is not specialty, but they have 2 beds available. Right? I can send a couple of critical patients, but now I got to find another place to send everyone else. Okay, so again, they have to determine where all these different patients are going, so they can tell us, hey, you're going to take these 4 patients, you're taking that hospital down that way.
And technically, over time, that can be one of us because we have experience.
Mm-hmm. Yeah, that's why I said you're going to kill a lot of people, sir. All right. So, with staging supervisor, okay, they're the ones in charge of the staging area. Okay, so again, they're going to be the ones who are talking to incident commander, for example, saying, hey, we have this many people here at triage. All right, do we need anyone else? No? All right, cool. We're going to start sending some guys over to transport then. All right, that way we can start getting those patients out of there. Okay, so they're going to go ahead and start delegating where we go. They're going to be taking down our information so that way we can be accountable for personnel. Right, so write down, our names, unit number, company we work for. That way when we come off shift, right, they can go and check us off. All right, they're done. All right, and then bring in other people as well. As far as the rehabilitation supervisor, okay, they're going to be the ones in charge of where we are going to be staying in the case of a large-scale event where we have to be there for multiple days. Okay, so we're going to have our own area for rest. Okay, so we're going to have our own sleeping areas, right? Food, right? Places to wash, things like that. Now, are we going to have rehab areas for every single mass casualty incident?
No.
No. Okay, because an MCI is technically defined as anything with 3 or more patients. Okay, now that depends on the resources available and whatnot. So here in LA County, 3 or more patients, it's not really that much of a strain on our system since we have, at least 8 people showing up on scene. Right? But in other places where it's more rural, could 3 or more patients be an MCI?
Yes.
Yeah, right? Because now we have to call for additional help than what's available when we actually get there initially. Okay, now in that case of 3 or more patients, right, we're not going to have, a sleeping quarters set up, right, a little bit down the road when you got a 3-person injury. Okay, so they're going to make sure everything's good to go. They're also going to provide any treatments that we may need, right, if we get injured with minor injuries, any type of lacerations, musculoskeletal injuries, things like that. All right, we could also be assigned to work in the rehab area, where again we'll be treating other people, right, that are coming in with injuries. So, for example, if we're working a large structure fire, okay, we may be at the rehab area treating firefighters for what kind of injuries? Smoke inhalation, burns, yeah. Okay, so we're going to be there just sitting there taking care of anyone else that comes in, whereas patients are going to be going to the treatment area. All right. When it comes to extrication and special rescue, okay, we typically work literally side by side, right, with the extrication team, because once they pull patients out of rubble, we're going to have to triage them, possibly do some basic treatments, and then move them out to the treatment area and then transport later on. Okay, so we'll sit there with the stretcher. Okay, once they pull them out, we'll load them up, do what we got to do, go to treatment, do what we got to do there, and then take them to the hospital. Okay, now depending on the EMS system, again, it just may be the same crew. Like, large urban areas, LA, New York, right, major urban areas, they'll be doing extrication and medical with the same person, since they are cross-trained. All right, when it comes to the morgue supervisor, okay, they're responsible for patients who have died on scene. Okay, so they're going to be the ones who are going through collecting different body parts, right, from whatever the event is. Okay, organizing bodies, tagging them for identification later on, and of course transporting to the morgue. All right, so any patients who have been black tagged, okay, they're all going to go to one central area, preferably away from the treatment area, so that way nobody can see. Right? And as far as physicians on scene, again, they can go ahead and temporarily expand our scope within reason, and they might be able to make those difficult triage decisions, which triage is relatively straightforward, so we don't have that many instances where it's like, kind of deal. Right? But if they need to, they can go and do that kind of stuff. So, as far as NIMS, the National Incident Management System, it's kind of the overall thing that created this. Okay, implemented in 2004. Right, so when 9/11 happened, they didn't have this whole system set up, and that was kind of the catalyst for actually developing this whole system. Right, so federal government started going ahead and providing standardization and terminology. Right, that way again we're communicating, we don't have that communication breakdown. Okay, so the incident commander is the incident commander. All right, it's not the boss, it's not the head honcho, it's not like that. It's incident commander. All right, who is going to be interchangeable, right, from different people. Okay, standard certifications as well. Now the ICS courses you guys took, 100 and 700, are just 2 of many different incident command classes. Like I said, people get degrees in this kind of stuff, right? So there's a lot of different courses that you can take, right, to get fully certified in all of our incident command system stuff. Okay, but for us, 100, 700, it's like what, intro and like some other things, right? It only pertains to our job. Because there are other things that we're going to relate to planning and finance and logistics and all the other kind of crap. All right, but since we're operating under operations, we only need those 2 certifications.
Do we ever get asked to do ICS 120?
No. All right, so as far as the rehab area, right, this is it here, or actually the whole components rather, is this whole. We got the command center. So again, that's where the actual incident commander is going to be located. Okay, it's not usually going to be on scene. It's going to be set off just a little bit of ways where it's safe, preferably uphill,
Upwind
or upstream of the actual incident itself. Okay, so again, think of it like headquarters. They'll be calling the shots. We'll have liaison running out there, talking to different people. We'll have staging area, which again is where we're going to go, also uphill, upwind, upstream. Depending on the incident, it may be at the incident command where we're going to stage. All right, they may set up at a school gym. Okay, that's where the headquarters is going to be at, and that's where we're going to stage. And then we just go ahead and drive a couple blocks to wherever the incident's at, and we go and start going to work. Okay, we have the extrication area, which is where the actual scene is at, since we're extricating them out of that kind of stuff. The decon area, if there's a hazmat situation. Okay, because whatever happened to them can happen to us. And again, with WMDs, our biggest issue is not contamination, but cross-contamination. Okay, so we got to worry about patients bringing nasty stuff and getting us injured or ill, right, based on them not being cleaned off properly. Okay, and like I said, we'll be talking about hazmat, what they do later on. We got the triage area, which is pretty much close to the actual scene itself. Right, depending on the situation, maybe slightly out of the way for safety reasons. Treatment area, where we provide treatments. Supply area is just storage, where we're going to grab our equipment as needed and restock. Transportation area, where we're going to be loading up patients to get them out to different hospitals. And the rehab area is where we're going to stay. Okay, and again, per the incident, this is scalable. So we don't always have a rehab area, for example. We don't always need a decontamination zone. Right? We don't always need this or that. Okay, it's scalable depending on the incident itself. So I believe this was from the Santa Monica Farmers Market, where that old guy drove through and hit a couple dozen people, I think. Right? So they got all this stuff set up, and in the case of triage, right, it's happening right there on the street, right where it occurred. Okay, but it's something like a structure fire. Okay, are we going to go and stand right at the base of the burning building and triage patients? No, right? They're going to extricate them out, okay, to a safer place where we can start triaging patients from there. Okay, so again, that just depends on the incident itself. All right, now as far as an MCI, mass casualty incident, by definition, it's usually anything that involves 3 or more patients. Okay, so by definition, an MCI is anything that involves 3 or more patients. Or if it requires mutual aid, which basically means we have to call for additional help. Okay, and that depends on the EMS system. Here in LA, 3 or more patients, yeah, it's kind of bad, but it's not going to exhaust our resources. Right, we just call for a couple more ambulances and we're good to go. Okay, but in other places, right, we may have to call for a bunch of other people. All right, different ambulances, okay, different services may have to come as well. Right, and again, here in LA, we're spoiled because fire does just about everything. They're fire, they're hazmat, they're extrication, all right, they're ALS, they're BLS. Okay, but in other places around the country, fire is just that. They're just volunteers who know how to do some fire suppression and hold a hose. Okay, whereas the extrication team, right, maybe some guys that work at the junkyard and know how to use power tools. Okay, so we have to call for those resources individually as needed based on where we are.
If say like even if we're an EMT and say like we're certified in a special set of skills, can we tell like whatever like our whoever's in charge of us of those skills so they can possibly divert us to other things?
Yeah, that's fine. All right, so yeah, let's say you do have experience, right, with using the jaws of life. Hey, you know, I do have some extrication equipment. I am certified. Do you want me doing that? And they'll be like, no, you're cool. Just stay medical, right? Or yeah, go help them out really quick. All right, so we can go ahead and be bounced around wherever we need to based on our training. All right, with this, again, super duper flexible. So as far as patients and triaging on scene, okay, we go ahead and triage, doing all that kind of stuff, and then once everyone's been triaged, then we can start moving on to treatment if we don't have enough resources. Okay, so if I were to get there, why don't you mix it with water? If we have enough resources, okay, once they've been tagged, all right, cool, you guys are going to take them, start taking over that area, okay, as we're going through. But if we have 5 people, okay, we're all going to start triaging, do a whole sweep, cool, everyone's been triaged, all right, let's start moving these patients over to this treatment area so we can start treating them, and we wait until we have enough people to actually transport. Okay, can I leave my patients on scene?
No.
No. What's that called?
Neglect.
It's abandonment.
Oh, yeah.
Okay, so we cannot leave patients right on scene, even if it's an MCI. Right, we have to have somebody there to take care of those patients. right? Now, let's say we have law enforcement who's going to be there. Okay, their primary function is law enforcement, but they're also certified as an EMT. Okay, can I leave those patients with that law enforcement officer?
Yes.
No.
Oh.
Okay. Right. Their primary function is law enforcement. Okay, they don't have a fully stocked ambulance. They don't have jump kits. They don't have the equipment that we have to help out. They got the training, but not the available resources. Okay, so I cannot leave them, right, with the patients. So we can have at least one EMT there because we already have our resources expanded as much as we can. I can leave at least one EMT there and transport others. Okay, but I can't leave a cop who's also got EMT training if their primary function is law enforcement. Same thing with fire. Right? Yeah, fire and EMS, they're trained together, but again, firefighters don't have fully stocked ambulances since they're usually just fire. That's their primary job. Okay. So, as far as showing up to an MCI, okay, we talked about it a little bit yesterday. The first thing we do when we show up on a incident with a large number of patients, 3 or more, is declare an MCI. Okay, so the first thing I do is declare an MCI. So we get on the phone with dispatch, and we say, hey, we showed up to this crash. We have 7 patients. We're declaring an MCI. And step 2, we need to call for additional resources. And because we have multiple patients, who do we have to call for?
ALS?
No. More ambulances.
Oh.
Yeah, multiple patients, multiple ambulances. Okay, so we'd be like, hey, declaring an MCI, got 7 patients here. I'm going to need about 6 to 7 more ambulances, right, to our location. That way they can start sending those as we go. Now, between myself and my paramedic partner, who's going to be the incident commander? Paramedic. Okay, so the first thing we do is we start triaging these patients after we've declared an MCI, right? After we've called for additional resources. Okay, so we go and we start sorting these patients out based on the severity of their condition. Hey, this one's a yellow tag, this one's a red tag, this one's another red tag. We got a black tag patient over there. This guy's green, so he's going to walk over to this location. We start sorting out those patients, and then we can start treating to the best of our ability. As more and more ambulances start showing up, we can do more for the patients and then start transporting them out to hospitals as well. All right, now obviously in that case of a 7-patient call, do I need to set up a rehab area? No. Okay. We don't need to set up hazmat or decon or anything like that because, again, ICS is scalable. So as far as primary triage, that is done in the field, right then and there as soon as we approach. And then secondary triage is where we go in at the treatment area to see if the patient's getting worse, because in triage, you do not get better. Okay, so with secondary triage, we go back and we reassess the patients to see if they're getting worse, because again, you do not get better when it comes to triage. All right, and the secondary triage is going to be more like a regular patient assessment. Okay, we've already got them triaged, they're in the treatment area, so we can be a little bit more thorough with our assessment. Okay, we can do things like get more vitals. Okay, we can run secondary history. We can do physical exams. We can start doing things like that. All right, and start providing treatments for non-life-threatening injuries like splinting, right, spinal mobilization, whatnot. So, as far as MCIs, okay, again, large-scale events like this, we may have to call for more resources. Right, with an event like this where it's going to take at least a day or 2 to clean up, we may have a rehab area set up. Right, but again, if it's just a multiple car crash, not that big of a deal. Now, as far as triage criteria, okay, we have the same criteria as pediatrics with Jumpstart, green, yellow, red, and black tag. Now, as far as the triage tags themselves, they may vary depending on what we have and how big the scene is. Okay, if I've got hundreds of patients, I'm not going to necessarily have time to fill out all these triage tags. Instead, I'm just going to take some band tape and just tape it or tie it to the patient. That way they can quickly identify, okay, this guy's got a green tag around his wrist, he's stable. Right? That guy's got a red tag around his wrist, right? He's critical, we got to get him out of here. All right, but if we have the time, okay, we can go and fill out these triage tags that have a little bit more information about the patient. All right, now there's different styles of triage tags. So these are the 2 common ones. I'll pass those around. So with the different tags, first off, the last color that we see is going to be the tag of the patient. Okay, so because we haven't torn anything off and green's the last one, that tells me it's what kind of patient.
Green.
Green tag. This would be a
Yellow.
This would be a
Red.
and black. Okay, and again, can you get better in triage?
No.
No. Okay, so I can't be like, oh, they've gone from red to yellow. Oh shit, I gotta go back and tape it. Okay, it doesn't work that way. Once I tear it off, that's it. The best they're gonna be is yellow, but can they get worse?
Yes.
Yeah, and then I tear it off and now they're red. Okay, and red patients can obviously go to black. Okay, so we just go ahead and tear it off. There's gonna be certain information for things like vitals. So we got blood pressure, pulse, and respirations. Okay, we have the time in which you're gonna document as well. We have charts of the anatomical position for noting injuries, right, on the patient. So we kind of draw roughly in the area or a circle and just write a brief description of what it is. On this side here, we have time and date for the incident, male or female, patient's name, address, things like that. Okay, so just some basic information. And with these older school tags, okay, we have essentially those old paper receipts, right, where we go ahead and tear this off, right, and we leave it with us as the tag goes to the patient. Okay, now anytime we have a triage incident, we have to go back and fill out patient care reports for each and every patient. Okay, so that's why we need to fill these tags out and keep track of where they go. Right, because then I have to go back to a certain hospital and be like, hey, I'm looking for patient 915577. Do you guys have them here? Because we wrote down that's the hospital they went to. And they have to go through and be like, oh yeah, here you go. And then we have to fill out a patient care report based on the triage tag, okay, to the best of our ability. Right, now newer ones are gonna have barcodes, okay, so we can go and scan in on scene and then go to the hospital and scan in and we can find the tag. Right, this one's gonna have more information. So we have things like sludgem, okay, which is gonna be used for what type of exposure. Cholinergic or nerve agent exposure, okay, since these are all going to be different signs for that. So if I suspect that it was some type of cholinergic agent leak, I have to go and check whatever boxes they show, which would basically be all of them, okay. Auto injectors, okay, so we're going to write in the type, right, either the Mark 1 or the Duodot, okay. We go ahead and document how many times we hit them, things like that, okay. We have things for burns, same chart, vital signs, right? If ALS is given medications, there's a chart for that as well. Okay. Back here we have a little cheat sheet for actual triage itself, so we can determine, because even FEMA knows that you guys what?
Suck.
Right. Okay. We have our different criteria up here, patient information. Right. Now, as far as this tag here, okay, it says contaminated. So if the patient's contaminated, we leave it on, right? Because it's that bright pink color, so we can easily identify, oh crap, this patient has some type of stuff on them. Now, if the patient's not contaminated, what do I do with it?
Tear it off.
Tear it off. Okay, we tear it off, that way we know, okay, it's good to go. All right, and then same deal, the last color we see is going to indicate the actual tag of the patient. All right, so we'll go and do that, and we'll just drape it around the patient's head. Okay, these aren't toe tags, okay, because they're not dead yet. Right, we just go ahead and drape it around the patient's chest, and we go from there. So, as far as start triage, simple triage and rapid transport, again, it's an algorithm. Okay, now in the order of our triage assessment, we use RPM. What do we use?
RPM.
What do we use?
RPM.
Right, RPM. Respirations, perfusion, mental status. Okay, so for triage, we use RPM. Respirations, perfusion, and mental status. And we go in that order. So we start off looking at the patient's respirations. Okay, we look to see if they're breathing or if they're not breathing. Again, it's just an algorithm. Right? Do they meet this criteria or do they not? So if our patient's not breathing, we'll just start there. So if I walk up to an adult patient and they're apneic, okay, the first thing I do is I open their what?
Airway.
Open the airway. I don't care about spinal injuries when it comes to triage. Okay, so we open up the airway by doing a head to chin lift, and we look to see if they're breathing after that. Okay, if we open the airway and the patient's still apneic, right to a black tag. Okay, so if I walk up, I got an apneic adult, crank back on that head, open up the airway. If they're still apneic, all right, that's it. Black tag, move on to the next person. If after opening the airway they start breathing on their own, then we go and slap a red tag and move on to the next patient. Okay, so if I walk up to an adult, they're initially apneic, crank the head back to see if they start breathing or if they're not breathing. If they're not breathing and they're still apneic, black tag, move on. If they start breathing after that, red tag, move on. Now, let's say I approach a patient and they are breathing. Okay, now I have to look at the rate. Okay, and we're using 30 as the benchmark. If they're over 30 breaths per minute, automatic red tag. Okay, so breathing over 30, that's an automatic red tag. If they're breathing under 30, we move on to the next step. Okay, so respiratory rate over 30 is an automatic red tag. Respirations under 30, you move on to the next step, which would be checking perfusion. And there's two ways of checking perfusion. I can check a pulse or I can check cap refill. Now between the two, which one is the better indicator of perfusion? Pulse. What is it?
Pulse.
What is it?
Pulse.
But again, triage, you can go either one. Okay. Now, if our patient has delayed cap refill, okay, or a thready or absent pulse, and they're breathing, that's an automatic red tag. Okay, so delayed cap refill, right, or an absent pulse, scratch thready, just absent. Okay, that's an automatic red tag. Right, as far as the patient having an absent radial pulse, because we can't feel their pulse, right, we already know their systolic blood pressure is less than a what? 80. Right? So if they don't have a radial pulse, we already know their systolic BP is under 80, right, which means this patient's hypotensive. Significantly hypotensive. Okay, if they have any type of bleeding, we take care of the bleeding, slap a red tag, and move on to the next patient. All right, now as far as your bleeding control, that just depends on the scene. I can do my regular bleeding control methods, or just slap on a what?
Tourniquet.
Slap on a tourniquet. Okay, it just depends on the situation and the patient himself. Okay, now if our patient has a radial pulse and has immediate cap refill, okay, then I move on to mental status. So perfusion checks out. All right, then I can move on to mental status. And this one's super simple. Either they can follow simple commands or they cannot follow simple commands. Okay, so they can either follow commands or they can't follow commands. If they can follow commands and everything else is checked out so far, then they get a yellow tag. Okay, so if they can follow simple commands, they have decent perfusion, right, and they're breathing okay, once all three criteria have been met, then they can get tagged yellow. If the patient can't follow simple commands, now they get a red tag. Okay. So we go through and we run this assessment, and it should take no more than about 15 to 20 seconds per patient to do a triage assessment. Okay, so as I walk up, I can see chest rise and fall, right? I can go ahead and check the cap refill or check for a pulse really quick and ask them, hey, can you wiggle your fingers? Cool. They get tagged whatever color, and we move on to the next patient. Do the same thing over and over and over and over and over and over again, okay, as we triage different patients. Now, in the case of pediatrics, what kind of triage do we use? Jump start. Okay, where again, we use the same criteria. Okay, and you have to be able to switch on the fly. Now, I can be like, all right, we're going to do a sweep first of all the adults, and then we go back and we do it to kids. Okay, you go from an adult to a kid to a kid to an adult. You got to go back and forth, back and forth, back and forth, properly triaging your patients. Okay, now as far as RPM, again, that's the order in which we actually assess our patients. However, a nice little nifty tool, okay, that we can use to actually determine the criteria is using what I call, or what I've been told, 32 can do. Okay, so I was taught this little trick from somebody else. Okay, and this is what I use to determine what the severity of my patient is. So 30 is in relation to what? Respirations. Okay, so if it's over 30, I already know they're what? Red. Yeah, you suck, sir. Right, if they're over 30, we already know it's red. Okay, if the cap refill is greater than 2 seconds, what do we know?
Red.
They're red tag. Okay, and if our patient cannot follow commands, what do we know? Red tag. Okay, but if we have respirations that are less than 30, right, cap refills less than 2 seconds, and they can follow simple commands, right, then we know they're what?
Yellow.
Then we know they're yellow. Okay, so we just go over under for each one. Okay, and 32 can do is also the order in which I'd be running this assessment. 30 is in regards to respiration, so check first. Okay, I do 2 for perfusion, and that's only in relation to cap refill. All right, and then can do is their mental status. Now, in the case of a patient who is a green tag or walking wounded, they're stable and they have injuries, right, that still allow them to walk. Right, Right? So again, I would say, hey, if you guys can hear me, I want you to go stand over by that light pole right there, and all the patients who are able to get up and walk over there are automatically tagged as what?
Green.
As green tag. And then when I go back and do secondary triage, oh crap, these patients are actually yellow tag, right, for some of them, where some of them are still green tag. Okay, and we go back and reassess them. Right? But once I move a patient to a treatment area, if they're yellow, can they become green?
No.
No, because again, you do not get better in triage. You only get worse. Okay, so once we run through our triage assessment, we go ahead and start transporting or treating those patients by moving them over to the treatment area, and then do whatever treatments we have to run.
You tag all the green tags last, right? Like you tell them to move
Yeah.
to red, yellow
Yep.
tag.
And you just go get their information, green, 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 and that's it. All right. So when it comes to Jumpstart, again, we'll be using that for our pediatrics, less than 8 years old and or weighing less than 100 pounds. Okay, not the same as regular start triage. Of course, we already covered that. So green tag patients are still the same. They're still walking wounded. Of course, it does not include infants because they don't know what we're saying and they cannot walk. For my yellow tag patients, okay, if they're breathing on their own between a rate of 15 and 45 breaths per minute, they have a palpable peripheral pulse, and they're least responsive to painful stimuli, okay, that's all going to be yellow tag criteria. Right? We don't have can do for kids because if I have a 2-year-old, are they going to follow simple commands anyways when they're healthy? No. So we'll go ahead and make sure that all this stuff is set up and ready to go. And if that's all good, cool, yellow tag. But for red tag, how many criteria do you have to meet?
One.
Just one. Okay, any one of that red tag criteria, they're automatically red tag. So breathing less than 15 or greater than 45 times a minute, automatic red tag. Okay, if they're apneic when I walk up to them, the first thing I do is open their what?
Airway.
Okay, and if the kid starts breathing, automatic red tag. If the kid doesn't breathe, then what do we do?
Black tag.
No.
Start giving them rescue.
Right, we ventilate. Okay, so with kids, we give them one additional chance, okay, by providing ventilations. Remember, when kids usually die from medical problems, it's usually because of what? Respiratory issues. Okay, so we want to try to prevent that by giving them ventilations. Now, if after the ventilations they don't breathe, then they're what? Then they're black tagged. Okay, but for kids, we give them one chance after opening up the airway and provide those ventilations. If they have signs of respiratory failure, that's a red tag. Right? If they're breathing but don't have a palpable peripheral pulse, then they're obviously red tag. And if they're not at least responsive to painful stimuli, then they are also red tag. Right? Black tag patients are those who are dead or expected to die. Right? And that we usually determine pretty much right away. Okay, with adults, after opening the airway, okay, they're not breathing, so they're either dead or they're gonna die. All right? Keep in mind, we don't have the resources available to sit there and provide rescue breaths for a patient in triage. Okay, with kids, we do the 5 and we see what happens. All right. So when it comes to our roles and responsibilities, again, we're going to be working 3 T's: triage, treatment, transport. So here's an example of what a treatment area would look like. So we have a red tarp on the floor. So all the patients who have been tagged red go on the red tarp. All the patients who have been yellow tagged go on the yellow tarp, and my green tag patients go on the green tarp. Okay, so again, if you guys have seen any type of incident on the news, you might see, right, as they're flying overhead, right, the different colored tarps with people laying down on there. Right, that's indication of the triage area and treatment area rather. Okay, and usually nearby is where we have the transport area. Right, and I just think of that as like a warehouse and a loading dock. Right, so we got all the warehouse portion right here, and then the ambulances are right over here just to go and ship the patients out. Okay, here's where we go and do that secondary triage. Right, so can these patients who are on the red tarp, can they go to the yellow tarp? No. If they're not going to stay on red, they're going to go where?
Black.
They're going to go to black tag. Okay, which means we're going to get transferred over to the morgue, which will be somewhere around the corner out of the view of the public, right, and the patients. Okay, with the setup of the staging area, the incident command post, the treatment area, okay, it's going to be wherever we can put space to actually have that stuff occur. Okay, so again, parks, schools, parking lots, okay, any big open expansive area is where we may have this stuff set up, right, and that could be pretty much right on scene, just outside of scene, or a couple blocks away, wherever it's going to be safe for us to go and set that stuff up. Right. So, a couple of different practice questions here. So it'll be just like burns. Okay. So you guys are going to go ahead and write out.
We write it out.
Yep. So again, just another sheet of paper, so it's nice and visible.
What about legible?
That too. I'll even accept just the letter that it starts with.
Oh, I'll do letters.
All right, so we have a 27-year-old male patient, okay, who is able to walk to a designated area with no major injuries. Pretty straightforward. Nice color coded.
Okay.
Yeah, you can go ahead and just put them up. It's a little too dark, but I know. Cool. All right. So yeah, green tag patient because they are what?
Walking.
They're walking and they're wounded. Right? Walking wounded patients. Okay. Now with those green tag patients, right, we may not even have to transport them via ambulance. Right? What'll happen sometimes is we'll charter a bus. We're like, all right, we got 50 green tag patients. You guys are gonna go to the next town over and go to that hospital. Right? We'll have to do that. Right? Or yeah, they'll just basically sign out AMA of a triage scene and just go themselves. Okay, so we usually don't have to worry too much about those green tag patients.
When we do aim in the triage, it's gonna be like, you could die. Okay, go.
Yeah, we still tell them the risks. And again, it's just really a matter of them going to go get treated for themselves. All right, so next up, 36-year-old male, rest rate of 34, ready pulse, and his ANO times 2. Cool. All right, red tag. Okay, we know the patient's red tag right off the bat based on the first thing because their respiratory rate is over 30, right? So again, up above 30, automatic red tag. As far as ANO times 2, just depends, right? Because can they still follow simple commands if they're ANO times 2?
Yes.
Yeah. Okay, but the major criteria there is the fact they have pulse or respirations over 34 or over 30. All right, 19-year-old female with a compound fracture of the leg, respiratory rate 24, immediate cap refill, GCS 15. All right, this is a yellow tag patient. Okay, now as far as her vitals, right, is she stable?
Yeah.
Yeah, she's okay, breathing under 30, immediate cap refill, GCS 15. But can she walk?
No.
Why not?
Her bone's sticking out of her.
Exactly. She's got a bone sticking out of her left leg. Okay, we're not gonna have her hop to the designated area. Okay, because they're not hopping wounded, they're walking wounded. Okay, now let's say it was a compound fracture of her left arm. What would she be tagged as?
Walking. Green.
Green tag, because she can walk if her bone's sticking out of her arm. Okay. Same thing if the patient had some type of spinal injury, right? If they have a suspected back injury, okay, what tag are they at the very least? Yellow, because they can't walk. Okay, so we have to look at the injury to determine, hey, is this going to be a yellow tag patient? And we got to look at vitals as well. All right, so as far as the destination decisions, okay, this is all about the transport supervisor designating where they're going to go. Okay, so again, they'll be in communication with local hospitals and say, hey, you're a level 1 trauma center. I'm going to keep you open and then send people as needed. Okay, or we have a hospital next town over that's got a bunch of open beds. All right, I'm going to be sending all of my green and yellow tag patients out there because they can survive that longer transport time to a further hospital. Whereas the other local hospitals are going to be reserved for what patients?
Black and red. Or red.
Red tag. Yeah, because if they're black tag, where are they going?
Morgue.
They're going to the morgue. Okay, so they're going to go and keep that mortuary open, right? Which, again, it's not going to really be too busy there anyways. Just throw them and then come back, right? Okay, but we do want to keep those local hospitals open, right? We're going to rotate hospital destination, so as other hospitals open up beds by discharging patients, right, we'll contact them again and be like, hey, you guys have any open beds? Oh yeah, we discharged 3 patients 20 minutes ago. Cool, I'm going to send 3 more patients to you guys right now.
Has somebody ever been in black and like woke up like, oh, you're the
No?
No.
Zombies popping up?
Frankenstein's popping up. Okay, so again, we want to utilize the transport officer. Okay, so that way we have that stopgap where they're going to be responsible for that, and that's their only job. Their job is just to go, okay, you're going here, you're going there, you're going there, right? As we transport those patients out. Now, keep in mind, okay, regularly when it's just a normal call, all right, it's at very least a 1-to-1 patient to rescuer ratio. But in triage situations, when we're transporting, it could be a 3-to-1, 3 patients to 1 rescuer. Okay, so you can be in the back of the ambulance, you have a patient on your gurney, you got a patient in the captain's chair, and you got a patient on the bench seat. Okay, and you're going to be in the back, standing up, trying not to fall over, right, managing those patients as you're going. Okay, so you can have, a red, a yellow, and a green tag patient all in the back of your ambulance as you're going to the hospital. Right? Or you can have, 2 yellow tags or whatever, depending on the situation, and you have to manage all those patients. All right, and again, those green tag patients, they may not need an ambulance. Again, we'll just charter a bus and get them out of here, right, to the next town over.
Can we be the bus driver?
No. Okay, you drive the boo-boo bus. That's what you drive. Okay, so we'll go ahead and get those patients out and transported. All right, again, if we have a law enforcement officer who's on scene, who's trained as an EMT, can I leave the patients with them?
No.
No, because their primary job is what?
Law
Enforcement. Okay, even though they have the EMT training, they don't have the resources and equipment available to take care of those patients. All right, yeah.
So even if their vitals are complete shit, as long as they're walking, they're still great.
We'll go back and do secondary triage. Be like, oh crap, you're actually a red tag patient. Yeah. All right. Yeah, they'll be green initially just because they have injuries and they can walk. Now let's say that again, that 19-year-old the compound fracture. Right? Let's say it was the arm. Okay, well it severed her radial artery. Oh shit, she's actually in shock. Right? She can walk at the time, and then we go back and be like, oh yeah, you're yellow tag. All right. We'll take our break here. So we'll come back. We'll come back at 5:25 on Hazmat. Anything that can cause harm to anybody, right, on scene. So usually chemicals, right, flammable material, things like that. Excuse me. All right. So obviously, when that stuff arises, if the scene's not safe for us, do we go running in? No. We have to make sure we make that scene safe by calling for additional resources, i.e. Hazmat. So we have to try to understand at least basics of Hazmat. Usually that Hazmat is bad, all right, and it can cause harm to us. All right. So we need to have a general understanding, all right, of what's going on. So if we see or suspect some type of gas, should we go walking up and start breathing that air? No. Okay. If I see liquids on the floor, should I go and start touching it? No. If there's any solid material, should I go and pick it up? No. Right? Because again, all that stuff can cause harm to us, so we want to leave it as is. All right. Now, when it comes to Hazmat, can we always see it? No. Can we always taste it?
No.
Smell it? No. Okay. Again, a lot of things, right, can't be observed, right, and you don't know it's there until you know it's there. Okay, so we have to go and suspect the possibility of Hazmat. So for example, if we have a tanker truck, okay, it could be totally empty or it could be fully loaded. Am I going to go walking up to find out? No. Okay, we just assume the worst and hope for the best. Okay, we are going to be talking about DOT placards. Pretty exciting stuff. Okay, you have to know that. So when it comes to hazardous materials, again, anything that can cause harm to us, right, usually via chemicals. So these are just some examples of hazmat situations. Obviously, tanker trucks, okay, that involved in car accidents, right? They may be leaking either gases, fluids, or solid substances. Okay, structure fires, okay, especially at things like warehouses and factories. Okay, are there chemicals in those situations?
Yes.
Yeah. Okay, so when they combust, they themselves will produce chemicals, right? So regular fire produces chemicals that we don't want to inhale, like carbon monoxide. Okay, but if other chemicals are actually igniting, then things are a lot worse. Okay, right, build of methane even, right? Methane, if there's any type of combustion nearby, what happens? Boom. Okay, so we have to worry about things like that. So septic tanks and all that kind of other crap, literally, all right, we got to think of. So when it comes to hazardous materials, it's not always going to be marked. Okay, so not every single situation where hazmat is involved is going to be marked with one of these placards. Okay, now some things per DOT regulations have to be marked with placards, right? Your tanker trucks, okay, they need to have DOT placards on there if they're transporting hazmat. Okay, but things like the company that's transporting them, right? For example, FedEx, okay, if they're carrying a hazmat box, are they going to put a placard on the outside of their truck? No, it's only going to be outside of that box, but again, if it tips over, we don't know it's there until we know it's there. Okay, so the company that's transporting the equipment is not always going to be the most reliable source if hazmat is present. All right, so as far as different types of containers, there are bulk containers, which are going to be super duper large containers, and non-bulk containers, which are relatively small containers. Okay, so for example, here we have a bulk container. It's going to hold thousands of gallons or liters, whatever your unit of measurement preference is. Right? It's going to hold a bunch of that stuff. Sometimes they'll have structures around them to support them. They usually have some type of system for safety in the case of pressure release valves or whatnot. Okay, where if they do combust or get super duper heated, they don't explode, they'll at least start venting out pressure. All right, so here we have these intermodal tanks, which are just stackable, large containers that again can hold hundreds, if not gallons, or hundreds of gallons of stuff. All right, and it just depends on what it is. Sometimes they're pressurized, sometimes they're not. Again, it just depends on the substance that is there. As far as non-bulk, okay, that can include things like your 55-gallon drums. So they're still fairly large, but compared to the other stuff, they're not really all that big. Okay, so we can have these large 55-gallon drums be non-bulk, but also your little, gallon and a half, 2-gallon gas tanks are also considered non-bulk containers. Because is gasoline hazmat?
Yes.
Yeah. Okay, so with these, they are going to be labeled, or at least they should be labeled, right, with stuff that is going to be inside of them using those same DOT placards. All right. So as far as the hazmat, again, not always going to be that green cloud of gas that's emanating from the container. Okay, sometimes it just looks like smoke or steam. Sometimes we don't see anything at all. All right, and there's a video of some cop who was responding to like a stall truck or something like that. Right, just walking, and then just drops. Right, had no idea there was any type of hazardous gas in the air. Just walking, breathes it in, drops dead right where they stand. Okay, so again, we don't want to go anywhere near this stuff, and if we have to, I don't care if there's a patient inside of that cab, because whatever happened to them can happen to us. Okay, we're gonna chill in our ambulance a couple hundred yards away and be like, yeah, I see a placard there, right? And then we'll try to see what it is and call for the additional resources to make that scene safe. Obviously, that being hazmat. So when it comes to the placards, okay, again, you will have to know your different classes of placards. Yay. Okay, so as far as class 1, okay, these are going to be general explosives. So anything that goes boom, boom, okay, is considered a class 1 hazmat. All right, they are usually divided into different subcategories. Okay, so it'd be 1 point whatever. You don't have to worry about the point whatevers, just know that class 1 is explosive. Class 2 are going to be gases. Okay, and there's different types of gases going from flammable gas to non-flammable gas, oxygen and other inhalation and asphyxiants. Okay, so any type of gas will be class 2. Class 3 is our flammable liquids like gasoline. Class 4, right, it's going to be flammable solids. Okay, so anything that is a solid that is flammable will be classified as class 4. Class 5 are oxidizers, so things that will react with oxygen. Class 6 are different types of poisons. So anything not good for us will be class 6. Class 7 are radioactive materials. Class 8 will be corrosives, which can be strong acids or strong alkali. And then class 9 is any other miscellaneous hazmat that doesn't fall into one of these different categories. Okay, so bad stuff that doesn't fall under any other category would be class 9. All right, in that back room, we have an example of just about all of the different types of placards that are back there. Okay, but we got a couple others here. Now, in addition to the actual class number, on some placards, they may have a 4-digit code, like we see on this one here. Okay, and these 4-digit codes are going to correspond to the specific hazmat that it actually is. And we'll go ahead and look that up in our little handy notebook here, okay, to go and identify what the actual hazmat is. So now when you guys are driving down the freeway and you see a tanker truck, you'll be like, oh, that's a class 3, so I know that's got a flammable liquid. I should probably back away and put out the cigarette, right, just in case something catches on fire. Okay, and with the 4-digit code, you'll know what it may be if you want to take the time to look it up yourself. All right, these are all different classifications of DOT placards. Right, and again, if we are responding to a call, I want to look at the actual tanker itself, right, to be like, okay, it's a class whatever, so it might be this type of stuff inside. So again, here we have those different things. Obviously, they will fold, and we can go ahead and switch out the numbers as needed. Right? So they're going to go and switch it out, and the 4-digit code will correspond to whatever we have. Okay, so we know we have class 3s in here. So we know that we have different types of flammable liquids. 2 of the numbers are the same, so it's the same stuff. We have another one that's a different flammable liquid. We have some other, right, miscellaneous hazmat, right, as well as some type of corrosive. Okay, so if this tanker were to get knocked over, we have to worry about fire hazard, all right, and have to worry about contact hazards as well, right? And then whatever that is, we got to worry about whatever that is. Okay, so again, we'll just be hanging out, scoping through our binoculars, seeing what kind of number of placards we have as far as the class and the actual individual one, if it's available, and we'll cross-reference with our handbook. So these are updated every few years. Obviously, 2008 is pretty old school, so they do have newer versions of that. But they're going to be updating, adding different chemicals throughout the years. Okay, and we're supposed to have one of these in our ambulances. So if we do respond to hazmat, we at least can identify what it actually is. All right, as far as the material safety data sheets, or just now referred to as a safety data sheet, these are going to be found at areas where chemicals are going to be stored, such as factories, warehouses, right, even dialysis centers, okay, because they do use chemicals there, they have material safety data sheets. So if there is some type of spill of a chemical, right, we can ask the supervisor for a material safety data sheet. Right? They'll pull it out, and then we can look through it, or just ask them, hey, what was in that vat? Right? That way they can tell us, oh, it's this chemical. We look at the sheet, and we're like, oh, okay, so this chemical can cause this type of injury. It's going to have this type of basic first aid. Right? And these are precautions we got to worry about. Now, if it's a liquid chemical, how do we treat that?
Irrigation.
15-20 minutes out until
Right.
after start the burning.
Exactly, right? Flush them out for 15-20 minutes until after the burning is stopped. Where if it's a powder, what do we do?
Brush.
And then flush, right, for 15-20 minutes until after the burning is stopped. If it gets in their eyes, Ramon, what do we do?
You were to irrigate with the nasocannular, shooting water medial to lateral.
Right, we go and irrigate medial to lateral, whatever device we have, preferably cannula, right? But I want to make sure I'm going medial to lateral to get that stuff away from the other eye so it doesn't get in there. Okay? With shipping papers, right, they kind of give us an idea of what's at least being shipped, but that's about it. Okay, it's not going to give us any type of precautions as far as what to do. It just tells us, oh, we're going to be shipping this stuff. Okay, and again, the company that is shipping this stuff, they may not have to list placards on the outside of their vehicle, just has to be on the outside of the package itself. Okay, so if there is a FedEx truck that's turned over, right, and they're carrying a bunch of lithium-ion batteries, for example, okay, the package is going to have the DOT placard, but not the actual truck itself. Okay, so again, we don't know it's there until we know it's there. Now, as far as ChemTrek, they are going to be a resource for any type of chemical and hazardous material. So think of it like poison control for hazmat. Okay, so we go and contact them and be like, hey, we have this placard. I can't find it in my handbook. What is it, and what do we got to worry about? Right, and they'll tell us, oh, it's this chemical, so you may want to stay back, right, because these are the things that may happen. Okay, so they're going to be a more up-to-date resource, right, on certain chemicals. All right, so with a turned-over tanker truck like this, right, obviously we have to worry about, evaporation of gases. So even though we have flammable liquid, right, looks like it might be class 3, possibly, just based on the coloring of it. We have to worry about the gas evaporating, or the liquid evaporating rather, potentially combusting later on. With the NFPA diamond, these are going to be posted outside of usually buildings and whatnot. Right, and again, you'll start looking and identifying these things. All right, but we have this guy right here. Okay, so going from the top, we have red, which indicates flammability. And the scale goes from 0 to 4. So 0 will be non-flammable. Okay, so I can take a blowtorch to it, and it's not going to combust. So that can be an example of like bricks, concrete, right? Anything that's non-flammable. All right, going all the way up to 4, okay, where it's extremely flammable. All right, so it'll combust very, very easily. With the yellow, okay, that's reactivity, basically the explosiveness of material. So 0 is stable, so you can kick it, burn it, drop it, do whatever you want, it's not going to explode. Whereas 4, if you look at it the wrong way, it may explode. With the white diamond, that's where we have any special notes. So we have a couple examples there. So if there's a W with a line through it, that means use no Water. So if fire is going into a building, and they're going to see the NFPA diamond, they see W with a line through it, they're like, let's change out the hose, right? Because as soon as they start putting water on that, it may combust, right, and could possibly explode. Okay, so they have to find other ways to suppress that fire. All right, and then we have the blue diamond, which is going to be health hazards. Again, 0, right? No out of normal risks to us. Okay, whereas 4 is going to be super duper deadly. Right, now if it's located on a building, it's just going to tell us what type of stuff is in there as far as how dangerous it is. It doesn't tell me anything about the individual specific chemicals that are there. It just says, hey, in general, these are the risks of the contents inside the building. So if I see 4s everywhere, should we go in?
No.
Probably not. All right, and again, now you guys be mindful of this kind of stuff. When you walk in, you're like, oh, there's a blue 3. Probably should be careful. All right, so when we arrive on scene, we kind of talked about it with our triage stuff earlier. Okay, we want to try to approach from uphill, upwind, or upstream. Okay, or for the first ones there, tell people to come from uphill, upwind, upstream, so they don't get exposed. Right, we want to try to stay out of the danger zone. Don't take the highway there. Okay, so we want to stay out of there as best as we can. All right, and if we do happen to go up on scene, don't be like, oh shit, and then run back out. Okay, because now we are on the risk of cross-contamination, right, of everyone else that's not going to be in that safe zone.
So we just sit down and wait till we get green tag?
Oh, until we're at least cleaned off by Hazmat. At least you get a free bath. So, as far it wasn't directed at you, just saying. Right.
Very nice. It's fine.
So, as far as Hazmat, okay, they're going to go ahead and decon the patients. And again, if we go up on scene and we're like, oh shoot, I probably shouldn't have showed up. Again, we have to stay there, and they'll clean us off and treat us for any type of injuries that are there. Now, as far as the scene size up, okay, go through our pen man. Obviously, in patient assessment, we only taught you to do it how many times? Once, right at the beginning of the assessment. But realistically, okay, it is a continual process. Our scene's dynamic.
Yep.
Yeah, okay, they will change all the time. Okay, and you have to keep that stuff in mind, right? So it's not just a one and done type of deal, right? Because if I have a car that's knocked over on its side, could there be gasoline that could be leaking out?
Yes.
Could that gasoline catch on fire?
Yes.
Could that scene become unsafe?
Yes.
Yes. Okay, so if we're working, we're like, I smell gasoline now, right? And we start seeing it come out of the car. Oh shoot, right? Now we have to probably consider hazmat, right? Where they have to go and clean that stuff up. Okay, and again, hazmat situations can be as minor as that, right? Engine oil, transmission fluid, gasoline leaking from a car, right? We need hazmat to clean that stuff up. Or it can be that really bad, green cloud of gas that's emanating out of a tanker, right? Simple asphyxiants, things like that. So it just ranges on how severe the stuff is. So when it comes to hazmat, we want to get them going ASAP. Now again, here in LA, we're spoiled because fire does fire. They do EMS, they do ALS. They also do what? Hazmat. Okay. Of course, they have basic hazmat training, but of course, they have their advanced hazmat teams that are just like the difference between BLS and ALS. Right? Some firefighters can do simple hazmat issue, whereas the hazmat team is going to have more advanced training and that kind of stuff. Okay. So we may have to call for them ASAP because they will take time to mobilize and actually get on scene. Okay. So if we're sitting there, we've got a call, be like, hey, I have this placard with this number. I'm not going in there. Going to need to activate hazmat so they can come in, make sure it's good to go, and then start letting people come in on scene and start doing our job. Okay, we're going to hang out in the designated treatment area, which is going to be what we call the cold zone. In the what?
Cold zone.
All right, and in that cold zone, we don't need any protective equipment whatsoever aside from BSI to do our job. Okay, so in the cold zone, we don't need any type of PPE, no personal protective equipment, in order to do our job. But we have the hot zone, which is where the actual incident is located, and we have the warm zone, which is where decontamination happens. Okay, and we'll see some diagrams and talk about that again in a little bit. Okay, but we're going to be hanging out in the cold zone. The hot zone is where this stuff is happening, and the warm zone is decontamination.
For a car crash with gas leak, if there's gas leak, you just don't deal with it as an EMT.
We would tell fire, hey, can you throw some sand on that? That's about it. Again, hazmat can be that simple.
Oh, okay.
Right? It's not always going to require the big yellow jumpsuits and all that kind of stuff. All right. So as far as the different zones, again, hot zone is the area in which the incident happens. So let's say that's the factory where there was a chemical leak. Okay, so anything inside that building is considered the hot zone, and the only people that can go in there would be who?
Hazmat.
Would be hazmat. Okay, we're going to be out in the cold zone, where again we don't need any equipment, and the warm zone is where the patient's going to get decontaminated. Okay, so it's a transition between hot and cold. All right. Now, as far as the warm zone and the decontamination corridor, okay, it can be something as simple as that: plastic tarp on the floor with some kids' swimming pools, and that's it. Right. Now, the reason why we use all that plastic stuff is because it's generally not reactive to chemicals. Okay, and with the kiddie pools, we at least have some type of collection container. All right. Now, when we are conducting hazmat, okay, once we're all done, we have to properly dispose of all the stuff we've washed off. All right. I can't take this and just go throw it on the grass, right, and then call it a day. Okay, we have to go and take it to special collection centers. That's where we get the definition of decontamination. So, hot zone is, again, where the actual incident occurs. We have different levels of protection. So that is an example of a level A suit, okay, the highest level of protection. Right? And they obviously need to have all that equipment as they go into the hazmat situation. Here we have an example of level B, which is the second most protective. Some hazmat situations can require level B, and that's fine. All right, but generally they may be conducting hazmat and decon since they're going to be taking care of these patients. Okay, so again, all the stuff that they're scrubbing off and washing off will stay there, and they have to properly dispose of whatever's inside of that container. They can't just go dump it in the grass and then bring the next person in. All right, with the warm zone, it's where decon occurs. Cold zone is where we're going to be at when we're treating these patients. Okay, we don't need any type of PPE while we're in the cold zone. All right, so once that patient's been scrubbed down, they've been decon, cool, we get them, we do what we have to do, and we go from there. In the case of a large-scale incident, this is where triage and treatment's going to happen. Okay, hazmat is going to go in, clean them off, throw them out, and we take care of them from there. So, decontamination is the process of removal and proper disposal of hazmat. Okay, so decontamination is a process of removal and proper disposal of hazmat. Okay, so we are cleaning off whoever is contaminated and whatever is contaminated, and then properly disposing of it. So again, we're not taking that pool and throwing it in the grass and calling it a day. We have to take it to special collection sites, but they have to go and dispose of it properly and safely so as to not contaminate other things. All right, so these guys, for example, they all just came out of the hot zone. Those guys are prepping the warm zone, and they're just going to sit there and wait until they get cleaned off. And then once they get plugged out over there, for example, then they can take off their hazmat equipment and just start walking out and be totally fine. Okay, and again, in that cold zone is where we're going to be hanging out. So, as far as treatment of patients, any life-threatening treatments that have, or any life-threatening injuries, right, that have to be assessed, will be managed right there. Hazmat has very, very little, if any, medical training in most situations. Okay, their main job is to deal with the patient.
Clean them.
Decontaminate. Okay, so they clean off and properly dispose of any type of hazmat that they come into contact with. That's their primary job. Okay, once that patient's been scrubbed off, then we take over patient in what zone?
Cold.
The cold zone, right, where we go and triage, treat, and transport those patients. All right, now in the case of most hazmat situations, okay, most life-threatening injuries come from airway breathing problems. Bless you. Okay, so again, there could be chemicals, right, that are in gas form. The patients may inhale, and if they inhale those toxic gases, Axel, what's going to happen to them? What do they develop?
Pulmonary edema.
All right, they develop pulmonary edema. So crap, now we got to worry about fluid in the airway. We have to worry about them compromising their breathing. We got to suction the airway as needed. Right, and then we can take care of any circulatory issues they may have, things like shock, right? We have to worry about chemical burns, start rinsing those patients off if hazmat hasn't done it already, address those burns, and take them to a burn center. Okay, so the main issue we got to worry about, aside from regular patient assessment, is just the hazmat itself and what hazmat will do for those patients as far as cleaning them off and getting them out and ready to go. Okay, so again, another diagram. We'll see another one in just a little bit. There's the hot zone, the actual issue itself. The warm zone is where the patients get scrubbed off. And here we are going to be in the cold zone where we don't need any type of PPE whatsoever to take care of these patients. All right, now if we are going to be in the warm zone or the hot zone, obviously we need different stuff. Okay, so we need the SCBA, or the self-contained breathing apparatus. Right, so it's going to be the respirator where they have their own oxygen source, since again they may be in a toxic gas environment. Right, 2 pairs of gloves, one for PPE, one for BSI. Right, goggles or face shield, protective coat, respiratory protection if the SCBA is not already provided. And at the very least, some type of fluid impervious apron that way stuff doesn't seep through and get to us. Okay, again, this is assuming we are cross-trained in EMS and Hazmat. Right, where we are going to have to go in and take care of those patients, or at the very least scrub them down.
Are we able to take hazmat cert courses?
Of course. So, as far as our job, triage, treatment, transport, for just a regular EMT, and if we are a working rehab area, right, who are we going to be treating in the rehab area?
Other people, other EMT.
Other hazmat.
Other rescuers. Yeah, other rescuers. Right, whereas obviously treatment is where we treat patients. Okay, so that's where we're going to hang out. Again, if we have additional training in other areas, then we may get thrown to those areas since we got the training to do so. So when it comes to our different types of protection, we got level A. So level A is, again, that fully encapsulated suit. We'll see pictures of each of the next couple slides. All right, so level A, complete protection. So they're completely self-sealed from the environment. They have their own breathing apparatus. It's a giant one-piece suit that's completely sealed. Level B is pretty much the same thing, but it's not one continuous suit. But they usually are sealed off using duct tape. Level C, right, is not going to be fully encapsulated. All right, it's not going to be sealed off. Okay, but they are going to have a little bit of a protection. And then level D is pretty much the most that we are going to have as far as protection as a regular EMT. Okay, it's a regular work uniform with maybe an N95 and a hard hat. All right, so as a regular EMT with no additional training, okay, we're going to be getting the least protective equipment because we don't need higher protection equipment. Okay, since we're hanging out in what zone?
Cold zone.
Cold zone. All right, we don't have to get decked out in all this type of PPE. So here we have our different examples. So again, there's a level A suit, fully encapsulated with our SCBA. Okay, one giant continuous thing. Exactly.
2319.
All right, level B. Okay, so again, it's not one fully encapsulated suit like a level A, but it is still completely sealed off. And again, things like duct tape, right, are going to go around the seal between the gloves and the cusp, right, just to hold and seal it off, right? But they also have self-contained breathing apparatus, so they will have their own oxygen, right, that's attached to a respirator. Level C doesn't have SCBA, but they still may be wearing a filter mask. Okay, they're not completely sealed off, so there's no sealing between the gloves and the boots. All right, and then here we are at level D, all right, where it's a simple work uniform with an N95 and again, maybe a hard hat. Okay, so because we don't need all that extra equipment as regular EMT, this is the most that we're going to have. As far as different types of radiation, alpha and beta radiation, again, super duper weak. Okay, gamma and X-ray and neutron radiation, super duper strong. So we have to worry about patients getting exposed to radiation burns and whatnot. And as far as assessment of a patient who's been exposed to radiations, we think of shielding time and distance. Lastly, with hazmat and WMDs, again, definition of a weapon of mass destruction designed to kill, maim, or destroy
As much
as possible. Okay, so designed to kill, injure, or destroy as much as possible. Right, with those different categories being be nice or CBRA, or be nicer, whichever one. And that's that. All right, so moving on to transport operations. Yay. All right, so day-to-day operations, behind-the-scenes stuff of our job. Okay, so we're going to go over different phases of an ambulance call. Okay, required equipment for ambulances, right? Documentation of some stuff.
Fun stuff, man.
Exactly.
Is there a national registry?
You betcha. Right? And it's the category you guys do the worst on because you think it's not important.
If we fail this, will we fail the national registry?
Potentially.
No.
Yes. Stay awake. All right. So, as far as our ambulances, obviously ambulances are designed to move patients from the scene to the hospital and provide care along the way. All right, like we talked about way back in intro. Okay, back in the day, right, an ambulance was a modified hearse. We're like, okay, we scoop up whatever's left of the patient on the street. Hopefully, we make it to a hospital. Oh crap, they died. Okay, well, let's just divert to the morgue and that's it. Okay, so between then and now, right, obviously our ambulances are designed to save as many people as possible as we're providing transport to the scene. Now, because of that, okay, a lot of EMS systems focus on rapid response, which puts us at danger. Okay, because generally when we go to calls, we're going code 3 because we don't know what's going to show up. As far as transporting to the hospital, it depends on the patient's condition, right? So we'll talk about code 3 operations, right? Ambulance operations, what we got to do, things like that. So, as far as an ambulance, it is actually set to a certain standard. So it's not like you just go buy, a U-Haul truck and modify it. And, all right, cool. Now I got an ambulance, right? We have to go ahead and do certain things to actually get them certified. As far as equipment and the components of an ambulance, we have a driver's compartment. Okay, so we obviously have a place for the driver and a passenger. All right, patient compartment big enough for 2 EMTs and 2 supine patients. Okay, so we can have up to 4 people in the back of an ambulance. Okay, so we can have 4 people in the back of an ambulance. And in the case of an MCI, right, it could be 1 EMT and how many patients?
3.
3, right? Still for a grand total of 4. Or it can have 3 rescuers and 1 very critical patient. Okay, but we generally can't have more than 4 people in the back of an ambulance, and even then, it still gets pretty damn crowded. Okay, we got to have equipment and supplies for actual treatment and management of these patients. Okay, the stuff that we'll go over. We need radio equipment to communicate, at the very least, between dispatch and ourselves. If we have an online protocol, who else do we have to communicate with? Hospital. Designed for maximum safety and comfort? Yeah, sure. Supposed to be, right? But that's stuff that the ambulance is all about. All right, to actually classify it as an ambulance, they need to have the Star of Life affixed to certain positions, right, and actually submit paperwork to the DOT and, in the case of California, CHP. All right, again, we are governed by what authoritative body nationwide? DOT.
Department.
Exactly, Department of Transportation. Okay, and our ambulances have to be in accordance with CHP standards. Again, we're not really regulated much by Department of Health or Human Service or anything like that, like you think we are. Right? Our primary job is transport. Right? Moving patients from point A to point B, getting them safely, just like UPS. All right, so with our different phases of an ambulance call, there's a grand total of 9. Okay, going from the very, very beginning of you getting on shift, right, to terminating the call, right, and possibly end of shift, just depending on how many calls you run. Okay, so we got prep for the call, dispatch, en route, arrival and scene, transport, all that kind of crap, which we'll be going over, right, having a couple of slides at the very least for each one of them. So we know what we have to do, right, for each and every call as we go. So starting off with preparation, okay, we have to do daily inspections, right, as well as monthly inspections of the ambulance. As far as the daily inspections, we actually do 2. One at the beginning of shift, one at the end of shift. Okay, so we have a pre-shift checkout and a post-shift checkout. The pre-shift checkout is designed to make sure we have enough equipment to actually run calls for the day. Okay, because we don't always get to go back to station after each and every call. Okay, so we got to make sure we have enough equipment set out in standards, in the case of California, set by CHP. Nationwide, right, DOT. And they're going to regulate how much stuff we need to have in our ambulance at a minimum to actually be classified as an ambulance and be effective. Okay, so we do that at the beginning of shift to make sure we're good to go, and I do it at the end of shift to make sure the next crew is ready to go. Okay, so anything we use during shift, we have to what? We got to restock it. Okay, and if you don't restock at the end of your shift, who are you screwing over? Next crew. Are they going to be happy with that?
No.
So who are they going to screw over?
You.
And it goes back and forth, and eventually, who's going to pay for it? The patient. Okay, so you need to make sure that you're just doing your damn job. Okay, I used 7 4x4s on this shift. I got to go back and replace at least 7 4x4s. All All right, so we put that stuff back. That way the next crew doesn't have to use that stuff.
Are you ever allowed to like overstock certain supplies, like put extra
Within reason,
boards,
certain
extra
stuff, yeah.
like that?
Yeah, I can't throw in 2 gurneys, right? But I can throw in an extra 5 4x4s. That's fine. Right? I can throw in an extra splinter too. Right? That's totally fine. Right? You got to have at least the minimum of stuff there. All right. So we got to go and do daily inspections, not only of the equipment in the back of the ambulance, but the actual ambulance itself. Checking its fluids. Okay. Making sure that it doesn't need an oil change. Checking the tire pressure. Right. Make sure there's enough coolant in the actual engine. Okay. Now we don't have to go and do the oil change ourselves. Right, but we at least have to take note of it, so that way the mechanics at the ambulance company, right, or whoever they send it to, they can go and do that stuff.
Is that for monthly inspection or?
We do it daily as well.
Daily?
Yep. We have to write down the odometer, right? How many miles are on the ambulance at the beginning of the shift, how many are at the end of the shift, all that kind of stuff. Okay, now as far as division of labor, usually the driver is the one who's going to take care of the actual ambulance itself, whereas the attendant is going to be taking care of the back of the ambulance. Okay, now that role can switch between you and your partner during the shift. Right, but usually at the beginning, hey, you're gonna drive first. Okay, cool. You'll take care of checking out the ambulance, and I'll take care of the back, make sure all that's good to go.
You have to get certified to drive?
Yep,
How
Is it hard to
get
do that?
certified?
we'll talk about it.
When do I get certified?
Wait, yeah.
We'll talk about it.
We'll be doing this during our ride-along. This is like a daily inspection at the start of the shift.
Yep. All right. So also, we need to have equipment and stuff like that. Okay, navigation equipment as well. Okay, now we're not always going to use our GPS, right, when we're going to calls. Okay, can the GPS fail?
Yeah.
Can we not have cell service?
Yeah.
Yes.
Yeah. Okay, so instead you have to rely on the good old-fashioned Thomas guide. What? Okay, a map book. Okay, to go ahead and navigate to certain calls.
Don't we always work the same areas, so we can't just
Not
like,
always.
well, for the most part, are we working like
Not always. Better learn.
It's not that hard.
It's not. It's not. All right. If you guys need help mapping, I can always help you. It's not that difficult. Or ask your uncle or your grandpa.
We can call you.
I still don't have the address though, like, oh, that's this.
I'll tell you, yeah. And you
They'll
look
you
it up.
cross streets. They'll be like this place off of 10th and Examino.
Yeah.
Okay, 10th and Examino.
All right. So, as far as equipment in the back, okay, obviously we need to have a gurney. Okay, so we got to have a gurney in the back of the ambulance. Okay, we're gonna have our jump kit as well, right, as well as other stuff in the back. Okay, now most of the ambulances are gonna have these clear sliders and dividers and whatnot, so we can actually see where stuff is. And they're usually positioned in certain places of the ambulance where they're gonna be used. For example, my airway and breathing equipment, am I gonna have that by the patient's feet?
No.
No, where would I have that stuff?
By the head.
By the head, because the airway and breathing stuff happens in the head.
Mm-hmm.
Yeah, shocking. Okay, my trauma supplies may be in the center of the body, right, where we can go ahead and grab my trauma equipment. Okay, treat head injuries, treat torso injuries, treat leg injuries, whatever. Okay, miscellaneous stuff is going to be a little bit more out of the way since we may not be using it as much. So, for example, this compartment's here, so they're filling it with gloves, right, other equipment, isolation precautions, stuff like that. They may have that up above. Still easy to get to, but it's not going to be right there next to the patient. Okay, we may have other types of splints underneath the bench seat. We'll have backboards usually stored there. We may have some other stuff down over here, right? We have other equipment storage for our jump kits with shelves. Obviously, our house suction is there. House oxygen will be right around that region. Sometimes this will be a storage container. We may have sharp containers, sometimes oxygen tanks. So they're all set up differently.
How many rescuers are typically on the ambulance? Just 3?
Driver and you in the back.
Yeah, driver, you in the back, but we can have up to how many people back here?
4.
4. Right, so this is one of what they call a mod or modular ambulance. So it's the big kind of U-Haul type trucks that you see. So we can probably put 2 people in the bench seat. We got obviously a patient on the gurney. We have somebody else here, and there's another little cutout for a seat right there. So in the case of a mod, we could possibly have 5 people back there, right? But in the what I like to call the vanbulances, okay, which is more of a van style, usually it's just at least 4.
Did you ever drive the ambulance?
Not really.
Really? Isn't it more fun?
No work.
No, it sucks.
You like driving?
Oh, really?
Many times. Okay.
So, I would much rather just do patient care. So,
Really?
as far as that's what I went to school for. So, as far as medical equipment, right? We need to have certain stuff. We need to have, again, trauma supplies to stop bleeds, right? We need to have airway equipment, suction equipment, OB kits, because again, childbirth is what kind of skill? Unless it's BLS.
BLS.
Yeah, it's BLS skill. Okay, so we'll need our OB kits, right? For the jump kits themselves, okay, again, we have our jump kits all set up the same here, But are they going to be set up the same at whatever ambulance company you go to?
No.
No. But all the kids within that ambulance company, are they going to be set up the same?
Yes.
Yes. Okay. Now the whole purpose of the jump kit is to provide basic care on scene for just a couple of minutes. Okay, because our job is really to get the patient from the scene to where?
Hospital.
The hospital, right? In certain patients, do I have all day to sit there? No. Okay, for our trauma patients, how much time do we have on scene at most?
10 minutes.
10 minutes, and we call those minutes the Platinum 10. Okay, so it's just enough to get my patient assessed, stabilized, get them ready for packaging so we can go to the hospital and get them there, right? Now, if you think about it, we obviously have a lot more stuff in the ambulance itself. So even if I have a stable patient, okay, cool, let's just go and get them on the gurney, do what we can on scene. We'll get them in the back of the ambulance. We may not have to leave right then and there, right? But at least we have all of our equipment. I got better lighting. I can take control of that scene. And then once we're ready to transport, then we can go and transport. All right, but for those stable patients, okay, if they're fine, sure, we got the resources. We can just chill there on scene. All right, or we can move in the back of the ambulance, and then once we're good to go, then we can go. Or if it's critical, load and go. All right, we just go ahead and start driving as we go to the hospital and do whatever we can on the way. So, just some equipment. We have a CPR board. So if we have a patient who's in a soft area, okay, when we're doing compressions, they may just sink in. So for example, like throw out their mattress on bed, okay, we want to go and take them off their mattress, lay them on the floor, and then start doing compressions that way. Sometimes you don't have that option, and they use this a lot in hospitals, where the patient's head goes there, and we have something flat and firm to press against when we're doing compressions on their chest. Splinting equipment, okay, OB kits, and again our jump kit, which will be set up the same wherever you go. Okay, all those bags will be identical, right? And you should know your equipment enough to where if you have your jump kit behind you, do you have to look through it to grab your stuff? No, you should be able to go based off feel, right, and grab whatever it is that you need. Okay, that's how well you have to know your equipment. All right, as far as PPE, again, personal protective equipment keeps you from getting hurt, whereas BSI keeps us from getting sick. So of course we have our regular gloves, mask, eye protection, minimum BSI. We'll have gowns to wear as well, especially for childbirth, because is it a clean call? No. Okay. Other patients that have contact precautions, like the ones we talked about yesterday, right? We want to wear a gown to put a barrier between us and them. Right. Sometimes we have turnout equipment as well. Okay, so that's the stuff that the fire department wears. So fire-resistant, puncture-resistant clothing.
We get that?
Okay, if we're working on TCs, traffic collisions, right? Because there will be sharp metal, broken glass, right? We may throw on a coat really quick. Okay, we'll have hard hats, face equipment, hearing equipment, right? All that kind of stuff. All right, we need to have scenes to make the scene safe as well. So we're going to have cones and reflectors. Is it our job to direct traffic? No. Whose job is that?
Law enforcement.
That's law enforcement. Okay, but until they get there, we might have to, put some cones down, right, to make sure it's safe. We'll talk about parking and positioning, all that stuff in a little bit. We're going to have lights to light up the area. So we have lights on the side of our ambulance to act as floodlights, but we have other portable lights as well if we can't get the ambulance close enough where we can still light up the scene. We're going to have fire extinguishers, right, for smaller fires that we may be able to put out until fire gets there. Okay, we usually don't have flares because what do we carry in our ambulance that's kind of flammable? Really supports the
Oxygen.
Right, oxygen. Okay, so we don't have flares that are too close to the ambulance, right? If we have a leak or anything like that, then that'd be bad.
Do we carry Peloton lights or no?
What's up?
Peloton lights. Do ambulances usually carry Peloton lights or no? It's pretty much like those lights you see like on the back of the rig, but you can move them around. Very easily.
No, we don't have that stuff, but when we talk about extrication, they may have those larger lights available. We don't have room for that in our ambulance. Depending on the setup, again, we may have extrication equipment. Usually, though, if it's just an ambulance, we don't. Okay, we'll talk about extrication in the next chapter, okay, where we go through all this kind of stuff. Remember, extrication is the process of removing them from entanglement or entrapment. Okay, that's where you have to use the jaws of life and things like that to cut patients out if they're pinned. Alrighty, so with personnel and staffing, again, your class is set to what standard?
Basic.
DOT.
DOT.
Okay, it's a DOT standard, which is a nationwide standard. Okay, so if you were to take this class in, rural Pennsylvania, okay, you're still getting taught the exact same stuff, right? And in places like that, okay, our EMT is a dime a dozen. No. Okay, here in LA and other urban areas, again, we're spoiled. You can throw a rock and hit an EMT, and then 2 more will come treat that person. Okay, but in other places around the country, that's not the case, right? So as far as staffing, at the very least, you're going to have one EMT and somebody who is certified ambulance driver. And their medical training consists of basic first aid and CPR. And that's it. Okay, which means on scene, you may be medical authority as just being an EMT. Which means they're going to look to who? You. Yeah. No, not him. Okay, so again, you have to be able to run your assessment, do your job, and delegate somebody who's going to have a lower medical care than you, where you can basically say, hey, can you control that bleed for me? And that's about the most they can do. Or they can do compressions and maybe push some buttons on an AED.
So you can't do
So,
They're useless.
I know you talked about this before. This might be kind of off topic, but since the fact that they have less EMTs and stuff like that, if we say like went all the way to fucking like Hershey, Pennsylvania, or some shit like that, could we be like, hey, I want to work here as an EMT? Would they probably not do that?
What do you mean?
Because it's so rural out there and stuff like that. Do you think they like at certain places do they like pay EMTs and stuff like that, like, or is it just like
They wouldn't pay EMTs out there. It's volunteer. Right? Most of the country has volunteer EMS and fire. Right? In urban areas, we're spoiled because we get paid. Not very well, a little bit better than we used to. Right? But again, other places, a lot of them, they do it for volunteer. All right? So it's just the purpose of serving to their community, and that's about it.
So what happened to like, ALS being on there with us, or paramedic maybe? That's like a no.
That's a very, very unlikely situation. Because again, just think about population density in rural areas. Do they have a lot of people there to begin with? No. Okay, here we got a shitload of people, so therefore a certain percentage of us are going to be medical personnel. Right? Again, the fact that fire department gets paid a little bit too much in my opinion, but still very well. Okay.
let's not talk about that. Okay.
Okay.
I think fire's paid pretty good.
A little too much. They do get paid well. I'm not gonna
I think
argue
they
that.
pay just the right amount.
Okay. So,
My career to be paid.
anyways, right, because of that, we're gonna have higher training of EMTs, right, ALS, all that kind of stuff. Where again, we call for it, they're gonna show up. In other places, you have to wait, right? So, at the beginning of the year, I actually went out kind of near Hershey, Pennsylvania, funnily enough, Scranton. So, I was driving from upstate New York down in Pennsylvania, and some knucklehead actually got into a car accident right in front of me. Just was drifting and pretty much caught the rear fender of a tractor trailer, right? Pretty much got dragged along the road. Stable call, there was nothing going on. Dude was just high out of his mind. But pulled over, started rendering some aid. Patient was totally fine. Okay, cool, I'm just going to chill. Use this as an educational experience. Okay, how does rural stuff work here? So there was an off-duty guy who was part of fire, had his radio, and just calls it in. Hey, we have a traffic collision, stable patient on this scene, we're going to need extrication. Cool, I'm freezing my ass off out here, but I'm going to go ahead and see what's going on. So fire rolls up, state police show up, extrication team shows up, right? And they're pretty much trying to figure out how to remove the car outside of this thing. But it wasn't here like LA where fire shows up and that's it, right? Where they do just about everything else. Okay, so there, that guy had to call for all the other resources that he's going to need. Hey, I need this, this, this at this location. And of course, it was taking him 15, 20 minutes to get there, right? So different parts of the country all operate totally different ways. Right? Again, here we snap and everyone just shows up. Right? So when it comes to EMTs, right? Again, nationwide, 2 EMTs is pretty much the most you're going to get, right? Because ALS could be half hour, 45 minutes away, or just simply not available depending on where you are in the country. When it comes to our inspections, again, we have to make sure that all of our stuff is ready to go. Okay, usually done pre-shift, and then we'll do one post-shift as well. Make sure your gurney's operational as well. Okay, so just pull it out, do a quick lift test, make sure everything's good to go. If it's got to be serviced, swap it out. All right, just make sure that's all set and ready to go. As far as dispatch, okay, so once we actually get a call, it's going to come into dispatch. So dispatch is going to do the best they can with the limited information that they are going to receive. Do patients always call 911 for themselves? No. Okay. Is it always family or friends that call 911 for the patient? No. Sometimes it's some random person who's like, oh yeah, that person's passed out. I'm going to go and call for an ambulance. Okay. And they're going to be like, yeah, there's someone passed out on the street section. Okay, bye. And that's it. Okay. And then dispatch has to pretty much use that information that they get, however much or however little it is, relay that stuff to us. So they need to figure out the nature of the call. So what is it? At the very least, is it medical or trauma? Okay, the location of the call. Right? Where is it actually happening so they know where to send us? Will they gather an actual address? okay, a business name, intersections or cross streets, okay, or some other landmark, right, they can use so we can actually get there, right? The name of the person who's at the very least calling. So get name of the caller as well as a callback number. And they need that callback number because if they get disconnected, what do they have to do?
Call back.
Call back. Okay, so they'll get the callback number as well. That way if they get disconnected, they can call back. Or if we show up and knock on the door and no one's answering, what is dispatch going to do? Call them. Hey, dispatch, we're on scene. No one's answering the door. Can you get the callback number? And they'll go and give them a call. Right? We need to go ahead and figure out how many patients there are. So dispatch may ask, okay, how many people are there? Again, they'll do the best they can with the information they're given. If it's a medical call, how many patients do we expect to have?
One.
One. But if it's a trauma call, how many do we have?
Multiple.
Multiple. Depends. Okay, so for things like traffic collisions, right? Dispatch is going to assume there's going to be at least 2 patients at a minimum, especially if there's multiple vehicles involved. Right, and they'll say, okay, how many cars there are? There's 3 cars, probably at least 3 patients. I'm going to dispatch 5 ambulances just to be safe. And if we need more, then we just call for additional resources. If there's less, okay, well, only one person wants to be transported. All right, we'll cancel 2 of them. All right, and that's it. Okay, and then any other relevant information that may be needed, such as gate codes, right, to get into certain places. Okay, more detailed instructions if it's in a community, right, what, block number or anything like that. Okay, dispatch must be accessible 24 hours a day. Okay, that's even going for IFT companies where they're just doing scheduled transfers. Okay, and discharges and whatnot, they still have to be accessible 24 hours a day because you can pick up patients 24 hours a day. But of course, 911 always has to be available. All right, when we're going en route to the call, okay, this is the most dangerous part of the call for us. Okay, because when we usually get to call, since we want to get there as quickly as we can, we have to transport code 3. Okay, and when we're going lights and sirens, does everybody know what to do?
No.
Absolutely not. Yeah. Okay. All right. Some people just don't know or just don't care. Okay, so this is where we tend to get into a lot of car accidents. So when you're going to the call, okay, because we're going to have the driver who's obviously driving, the attendant is still in the front seat, they're usually acting as a spotter, right, just helping to clear, right, as you're going to the call. Okay, they're also going to be navigating. So they'll be looking up on the map book, right, okay, where do we have to go? All right, calling out turns and directions and whatnot. If we have our CAD, or our computer, okay, we'll go ahead and review dispatch info if dispatch were to update us. Okay, so if dispatch is still on the phone or the person were to call back and update what's going on, we'll get that information and then we can just go based off of that. So, like I told you guys the other day, right, we got called out for a seizure, turned out being a full arrest, right? We initially got dispatched for a seizure. And then as we got there, oh no, it's actually CPR in progress. Okay, so now that call and that plan that we had changes. Or they give you an unknown medical, which is dispatch's way of saying good luck. Right, and then you just have to pretty much prepare for anything. Okay, we'll be figuring out what equipment we're going to need. Okay, so we get called out for a slip and fall. Might need to bring some splints, maybe a C-collar. Right, back in the day, backboards. Now, maybe not. Okay, we'll develop our plan of action. All right, so let's say Brett and I are running a call. All right, I'm going to have you run vitals. I'm going to go and take the assessment on this one. All right, we're just pretty much planning, figuring out what we do, so that way when we get there, we go right to work. Okay, dispatch may say, all right, fire's there. Okay, here in LA, fire usually takes authority of the scene. All right, so again, we'll just say, okay, well, I guess we'll wait to see what fire wants us to do, and we'll have a plan and go based off of that. Now, once we get up on scene, okay, we want to notify dispatch that we're there. All right, and whenever we get information from dispatch, you always want to let them know that you've received that info. So, for example, when you get the call, okay, you get on the radio or whatever form you communicate with and say, hey, dispatch, unit 27, we copy call, show us en route. Okay, because everything's going to be timestamped. So dispatch goes in, timestamps when we got the call. Okay, when we get up on scene, unit 27 dispatch, show us on scene. They timestamp it. Okay, now when we get up on scene, we're going to do our scene size up. Is it just a one and done deal in the field? No, right, it's a continuous process. So as we're going to the call, like we talked about in patient assessment, okay, I'm getting called to a fall at a factory. Let's use last Friday's scenario. Okay, I got to worry about chemicals, I got to worry about machinery, there might be fire issues, right, there might be multiple patients. Probably sounds like trauma, might be medical, we don't know yet. Maybe ALS is on the way, maybe need hazmat. try to identify the supervisor, see if they can shut down machinery, right? Let's bring our backboard just in case, right? Let's get extrication ready to go. Okay, cool, I get on scene. All right, I don't need extrication, right? I definitely will need SMR, don't need hazmat, we can cancel them too, right? As we're doing that and we get to the call. And as we're actually running the scene, okay, this stuff's starting to go on, so we may need this or may not need that, depending on whatever the situation is. Okay, so again, the scene size is always a continual process. All right, when it comes to parking on scene of a traffic collision, okay, if we're the first ones there, okay, we want to go and park closest to direction of travel. That way we can block the scene. All right, as far as traffic control, whose primary responsibility is that? That's law enforcement. But if they haven't showed up yet, okay, then we have to go and put cones and stuff like that to make it a little bit safe for us. Right, now as fire shows up, fire may be the ones who are going to park their engines there because they're going to act as a barrier. What's heavier, a fire engine or an ambulance?
Fire engine.
All right, fire engine. So if you have some knucklehead who's not paying attention and they plow into the side of the engine, at least, you know, it's going to act as a better barrier, whereas they may go right through that ambulance. Right? And now we have a bunch of patients because they're going to strike the scene itself. Okay, preferably, if we're going to be transporting, we want to park away from the scene and start as flow as traffic. That way all we do is load up and we just drive. Not have to worry about going around the scene or anything like that. We're already there, load them up, and go. It's a straight shot right out. Okay. We don't want to be right up on the scene either. Okay, in case there's hazmat or the possibility of fire or whatnot, I want to try to be someplace, say, up to 100 feet away, or at least 100 feet away. That we can go and get out of there as needed. All right, we'll leave our lights on. That way we can light up the scene. People know that what's going on. If we have our floodlights, we'll go and turn those on so we can illuminate the area, especially if it's at night. And if they have to be extricated, we'll assist the extrication team, right, to the best of our ability. And we'll cover that a little bit. As far as traffic control, again, that's PD's responsibility. Okay, but if they're not there, we'll go and take that upon ourselves. When it comes to transfer, that's going from on scene to the back of the ambulance. I don't have to update dispatch with this. I'd be like, all right, dispatch, I'm loading up my patient. 30 seconds later, all right, dispatch, we're ready. We don't have to do that. All right, let's let them know we're on scene. We'll get them loaded up, get them in the back of the ambulance, and then we tell them, all right, we're heading out. All right, we'll talk about lifting and moving patients as well. We'll talk about different devices and whatnot that we would use. Okay, but that is the transfer phase of the call. All right, when it comes to transport, then we go ahead and contact dispatch and tell them that we're going to whatever hospital we're going to. Try to provide an ETA to the best of your ability. And depending on policy, they may ask you how many patients you're transporting and how you're transporting them. Code 2, Code 3, 1 or 2 patients on board, or anything like that. So for example, you'd say Unit 27 dispatch, we're going to be transporting to Long Beach Memorial, ETA of 7 minutes with 1 patient on board, transporting Code 2. Right? Just that way they kind of have an idea. Dispatch doesn't want a field impression or provider impression. That's irrelevant for them. All they want to know is where are we taking them, how many we got, and what's the ETA. That's it.
Yesterday, you said that sometimes the nursing care facilities call the IFTs directly to try to get them to transport the patients if they're unstable, and then you said that we should call for ALS. Do we do that through dispatch, or do we just call 911?
Sometimes we'll just directly call from our cell phone.
Oh, okay.
And then we'll tell their dispatch, hey, we're such and such with this ambulance company, we're a BLS unit, we have a patient who's blah, 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 blah. We give them the report so they can tell ALS what's going on.
But we don't do it directly through dispatch?
We don't have to.
Okay.
No. All right, so if we have an online system, we'll go and contact the receiving hospital. Okay, and again, like we talked about patient assessment, when you're given that rater report, you want to make sure you're actually contacting the hospital you're going to, because you want to be like, surprise, I got a stroke patient, you didn't realize, right? Go to the wrong one. So just verify it's the right place. Give them your ETA as well. All right, that way they know how much time they have to start gathering their equipment. For reassessment, if they're stable, reassess every
15.
If they're critical, every
5.
5 minutes. Okay, and like it says there, do not emotionally abandon your patient. Okay, so that means talk to them every once in a while, in addition to doing your job.
Hey, how's life gone? How's your day been?
Exactly. How are the kids?
Well,
What about the
you know,
Lakers?
yeah.
Right? Anything like that.
Should we game last night?
Okay.
I hope you enjoyed that game. That's your one.
Okay. Now, as far as the delivery phase or the arrival phase, again, we contact dispatch. Hey, dispatch unit 27, we made it safely to Long Beach Memorial without incident. 1 patient still on board. All right, so we go ahead and just let them know that we're there. And then we'll get ready to go and transfer the patient, right? Transferring care. At a minimum, transfer of care requires a verbal report, but legally speaking, it has to be written down as well. So we need to have a signature of whoever we are transferring that patient to. All right, because if we didn't write it down, it didn't happen.
Ooh, phantom patient.
Okay. All right. So we'll go ahead and fill out the PCR. Depending on the situation, we don't have to give a complete patient care report, but it's got to be hitting at least a certain amount of things. We got to have vitals that are documented. Got to have a narrative filled out, patient information to the best of our ability. All right, that stuff we need to have on there. Other things we can leave out, so we don't have to have all the times, right, on the PCR at that point. Okay, for example, time we cleared the call, I don't have to write that on PCR and then leave a copy of it. We just leave that part blank. Okay, patient information as far as insurance, I don't always need to have that filled out on PCR when I hand it off, because they'll gather that information later on. Okay, but obviously need the patient's name if I can get it, right? Treatments provided, vital signs, things like that. Okay, certain EMS systems we can actually restock at the hospital, because some EMS systems we actually operate out of a hospital. So they'll have a restock room available in LA. Some hospitals will do that depending on if they have contracts with the ambulance company. Right, so we'll have an access code to get into their stock room to replace things that we commonly use, like bandages, dressings, right, things like that.
So like if we gave them our traction splint, we would go get a traction.
They may have a traction splinter too in that supply room, so yeah, we swap it out. Otherwise, they don't have it, we got to go back to station and get another one. Right, backboards, right, if you guys go to hospitals, you see backboards laid out outside. You find your company's backboard and you just take another one. Don't take another company's backboard, take your own.
What if we got like a prank board going
That is not.
No, because that's called
What if
theft.
there's something nicer?
Prank.
Yeah, what if there's something nicer and you just trade?
Just check the cameras.
Like,
Yeah.
What if we leave them something in return?
We're going to go on another call before you restock.
We're technically not allowed to, right? If we don't have our equipment, we have to go out of service, right? And if dispatch sends us on a call, they can get in big trouble for that. So that's one way we can get out of calls. Oh yeah, we don't have this equipment.
oh man.
No,
Dang.
shock.
My
I
shoes
lost
untied,
my
sorry.
OB kit in the last call. I can't remember the next one.
It's a stroke though.
I don't know. Regular
Be
EMS
pregnant
stuff.
and
So, blood clot. No. All right. So as far as that's what's going on. Okay. We can also decon. So decontamination and cleaning of equipment can happen at certain points. Usually, to be efficient, if the the attendant is in the hospital, given the handoff report, all that kind of stuff, the driver, once the patient's been unloaded, they'll go back, they'll clean the gurney down, do all that kind of stuff. Right? Or we can just go back to station and do the same thing. Right? But preferably, better to get it done with. That way we can go in service for the next call. Okay. Now, when it comes to disinfecting, disinfecting is killing pathogenic agents with chemicals designed for that purpose.
Bleach?
Yep.
We use bleach?
Sometimes. Okay, so disinfection, all right, is killing pathogenic agents with chemicals designed for that purpose. All right, whereas again, decontamination, even though in this case we do use those terms interchangeably, okay, decontamination is a process of removal and proper disposal of hazmat. Okay, but disinfection is killing all the nasty stuff that's on our equipment. All right, so we want to go ahead and wipe down whatever the patient has either come into contact with or we suspect they may have come into contact with. Because everybody's what?
Nasty.
Nasty. So we just want to go and wipe that stuff down.
Would it be bad just to wipe your whole ambulance down every time just in case?
Depending on the situation, yeah. All right, so if you got a patient who's got some type of respiratory issue, yeah, wherever they breathe, they're looking over here, wipe down this wall. They're looking over here, wipe down that wall. Right.
What's the nastiest your ambulance ever gotten from a call?
Childbirth.
Really? It's not like projectile vomiting just everywhere.
Nope. Mine was amniotic fluid sloshing around in the back.
Is there meconium up there?
There was no meconium.
No meconium?
No. All right, so as far as restocking, again, we can also restock as needed. Again, we can do it either at the ambulance or we go back to station. As far as post-run, pretty much those two will blend together. Okay, so this is after the call is complete. We transfer patient care. Again, we can disinfect the ambulance. We can finish up our paperwork. All right, and we just want to go and let dispatch know that, hey, we dropped the patient off. We're disinfecting the equipment. we'll let you know when we're ready for service.
That was fun.
Oh man,
Just
yeah,
went
roller
real
coaster,
cold.
bro.
Oh, we're not done yet.
There's more.
Yeah.
Huh?
But wait.
So, we'll go and do that. Now, as far as refueling the vehicle, okay, depending on our service, we may have to go and do it after the call, or we do it at the end of shift, depending on how many miles you drive and whatnot. Okay, the company is going to have gas cards that you would use to fill up your ambulance. You don't have to pay for it. Okay, so we'll go and do that if needed, and we'll tell dispatch that we're out of service until we can refuel.
Do we use do we use the city gas station? I know there is gas stations.
Depends. Yeah. Depends on how their EMS system works. Private ambulance companies, no, you don't get to,
Well, I know other like rescue situations have that situation.
Yeah. All right, so with post run, we'll go back and again clean everything up, restock. Right, again, everything all kind of blends together at the end of that call. So as far as example of disinfection, yeah, we can use a bleach solution. Okay, but it is going to be diluted.
Oh.
Just pour straight bleach. Back when we first started bringing students back from COVID, Matt sprayed freaking 1 to 10 bleach solution in here.
Hey, it's
I
a
was
good
hallucinating
food,
for the first couple of hours. I
Good.
had a really bad headache. All right, but again, we don't want to use things that are super duper concentrated because whatever happened to them can happen to us, right? And of course, inhalation of bleach is probably not the best thing for us.
Just
better
mix
than
some money
getting
in there.
sick.
Even better.
No.
He's a little high.
Well, you don't want mustard.
Wait,
No, thank you.
If you drink it and dilute it enough, can you kill pathogens inside of you without dying?
No.
If you shine light inside your veins, can you kill COVID?
No, you just have to swallow the UV light bulb. That's it.
Like,
All right. So just inhale it. So as far as other equipment, okay, we want to go ahead and get rid of it. So if we have any type of contamination with biohazard stuff like blood or other body fluids, can I just throw it in the trash?
Oh.
No, it has to be disposed of in the red biohazard bags, which then has to be disposed of in the red biohazard bins. Okay. Same thing goes for sharp containers. I can't just throw the sharp container right in the dumpster behind the Home Depot and call it a day. Okay. It has to be disposed of properly. All right. So terms cleaning. Cleaning is just visibly removing contaminants from the surface. Okay. So that's brushing off dirt, right? Picking up a piece of brain, whatever. Okay. That's just cleaning. All right. Whereas disinfection, okay, is again using chemicals designed to kill pathogenic agents as we're trying to get rid of all the nasty stuff that's there. High-level disinfection is use something super duper potent, like a 1 to 10 bleach mixture. And sterilization is killing everything right on that surface. Okay, usually using heat, like with autoclaves.
not just,
Right, we don't really provide sterilization of anything.
Is
Okay,
there,
we use sterile equipment.
is there any time in a situation like when we bring it in that they will sterilize our equipment or anything in there?
No. Right, most of the stuff we use is one-time use only. Right. So we'll be doing all that kind of stuff as far as cleaning up, making sure that everything's disinfected. That way we don't spread nastiness from one patient to the next patient to the next patient. Because like we talked about yesterday, right, some patients are immunocompromised, like geriatrics. Okay, we have to worry about reverse isolation where we can get them sick because even we are what?
Nasty.
Nasty.
Are there ever those sheet blanket things on there?
Like over the mattress itself.
The white ones?
Yeah, yeah. We'll have that for every gurney because I don't want them directly on the mattress because I want to be able to swap it out. And sometimes we'll use linen sheets to move patients.
What about
The paper ones,
what about the ones that go on the kitchen? Do you have those?
blankets, just regular blankets.
The little ones that you tie back.
Gown?
Yeah.
Oh, gowns for no, we don't carry gowns for patients.
Yeah, strict down.
We'll just throw a blanket on them. That's it. All right. So as far as driving, okay, again, it is our job to sometimes drive the ambulance. Okay, when it comes to driving fast, okay, driving fast does not save lives all the time. Okay, it puts us at greater risk, which can then, end lives quickly. So we have to make sure that we're providing the best patient care possible. Okay, going code 3 doesn't save us like all this time. Right? It maybe will save us a couple of minutes. Okay, and very rarely do those couple of minutes actually matter when it comes to transportation. Okay, those couple of minutes really matter when it comes to treatment of the patient. Okay, but again, our job on scene is to assess the patient, to stabilize the patient, and then package them for transport. Okay, in times of the essence, usually when it comes to stabilization, again, there are certain things where yes, we do have to get there fast, like complicated childbirth, limb presentation, prolapsed cord. Okay, those are probably the only conditions where we have to haul ass to the hospital, right? Because there's nothing we can do about that stuff.
Every other time it's just they're stable by the time they're in the ambulance, so it's just check a thing.
Yeah, you know, MIs and strokes, but again, we have more time. All right, but with childbirth, it happens super quick. Okay, so we have to make sure that we are familiar with our ambulance and how they work. Okay, so when you get hired by ambulance companies and you get certified in driving, okay, they will take you through what they call CEVO, think, or EVOC, one of those. But basically, evasive driving maneuvers for ambulances, right, and how to handle your ambulance. Okay, because it doesn't handle like your Honda Civic. Okay. As far as wearing seatbelts and shoulder restraints, okay, as we're going to the call, we should be wearing seatbelts because that's the most dangerous time for us. Okay. When we're in the back, we're supposed to wear seatbelts, right? But again, sometimes we have to get up and be mobile, right, and move around. So when it comes to driver requirements, okay, yeah,
I'm real cute up there.
go over that. So when it comes to driver requirements, okay, you have to have a medical exam, right, when you apply for your ambulance driver certification.
What does that mean?
That means you have to go to a doctor and get a physical.
Yeah, it's like with the driver that can't have like epilepsy and stuff like that. So you
Exactly.
test that out.
Yep. Yeah. So the doctor has to pretty much sign you off. Okay. You have to pass a written exam.
Right?
Yep. Okay. And the company that you will drive for has to take you through driver training, right, where they do all the basic training, all that kind of stuff. Okay. As far as age, it's more of a insurance thing, right? But a lot of ambulance companies won't hire drivers or utilize drivers that are under the age of 21. Okay. So if you guys are under 21, don't bother getting your ambulance driver cert because it's a waste of time. Trust me. Right? So, just go and stand by, right? Try to get hired as an attendant. Again, you'll get your patient care. And if you guys are going to, you know, different types of schooling, nursing school, PA school, things like that, they don't count in drive time. They only count patient contact hours. Right? So that's why it's better to be in the back because that's how you actually get your hours. Right? Now, as far as emotional maturity and stability, again, usually with insurance, that's why they don't want people under the age of 21. Okay? Now, as far as recognition of driver fatigue, okay, you can be working 10, 12, 14, 16, 24, 48, 96 hours, right, depending on your shift. Obviously, the longer you work, the higher chance of fatigue. Okay, and that's what happened here. So this is at the McCormick facility where our other campus is located. And obviously, EMT's got into a wreck. So what happened is the passenger was falling asleep. Okay, passenger sleep, that's fine. The driver was also falling asleep and fell asleep. So they were going back to station and then crashed into a tree. Now, as far as the actual damage, I have another picture, I just haven't added in. The passenger space intrusion, there's like maybe 8 inches between the edge of the seat and the actual dashboard themselves. Now, fortunately, the EMTs only had minor lacerations and that's it, right? Because of the way that they were sitting, right, the passenger was kind of curled up in his chair, so his legs were out of that passenger compartment and didn't get crushed, right? The driver hit the passenger side, right, with the tree. So most of the stuff over here is still intact. Of course, airbag deployment and things like that, and there were no patients in the back, thankfully. Another instructor was actually going to shift to drive that exact ambulance for his call, was first on scene, right? So he's there having to take care of his coworkers in the ambulance that he was going to be driving that day. And then later on, he actually got to an accident himself.
That same day.
That same day. Yeah. Right? So, yeah. And this was 6-7 months ago.
Oh, wow.
Right? And at the ambulance station, so there's the back gate here. Right there is a mechanic area. There's another ambulance. You can't really see it. Another one's not as smashed up. It's still smashed up. And then right across here, there's about 4 ambulances that are all damaged in some way, shape, or form.
So it's a common occurrence.
Accidents happen a lot, yes. Okay. Some of them are the EMT's fault. Some of them aren't. Okay. So you always, always, always have to use defensive driving techniques because obviously, does everybody in LA know how to drive?
No.
Absolutely fucking not. Okay. And again, right, with this, with fatigue, it can happen to us. Right now, legally, okay, if we call in fatigue, dispatch is supposed to give us time, right, to rest and things like that. Maybe we're calling a station or send us to a post where we hang out and get some rest.
Can you get in trouble for calling fatigue though?
Not
legally.
Technically, yeah, you're not supposed to. Can you abuse it? Yes. Right? And they can't necessarily punish you for it, but they may do other things to kind of
Punish it.
yeah. All right. So, just use it when you have to, but again, don't be afraid to use it either. All All right, if you start getting tired, right, your partner says, all right, they're good and they're qualified to drive, switch. Right? The passenger taking a nap is usually not that big of a deal. Okay, obviously as long as you're not in a call. Right? But if you're chilling or anything like that, that's totally fine.
Just whenever I go to sleep real quick.
So, like, are y'all just at your post until you get the call, right?
It depends. It depends on your shift, your company, all that kind of stuff. So yeah, for us, I very rarely hung out at station. We just got assigned to a post, and we just sit there and wait till we get a call. Yep. All right. So as far as driver anticipation, okay, again, we have to assume that nobody knows how to drive, and that's a very accurate statement. Okay, so drive defensively. Always be on the lookout for others. Okay, obviously you should not tailgate, and try to avoid tailgaters yourself. Right, and the best way to do that is simply tapping your brakes. Don't brake check, just tap your brakes. Right, letting them know that, hey, you know what's going on, and just if they're driving like an asshole anyways, just let them go.
Give them the bird on the way back.
No. All right, because then they will take your unit number and call your dispatch and file a complaint, even though they're obviously in the wrong. Okay. All right.
I
Yeah.
always wonder, do y'all ever like call the police on people who are like following you, like
Could.
so they can
If there's situations like that, yeah.
traffic?
Usually, though, again, if we're going code 3, we're usually busy doing something else. We may not necessarily call. Be like, hey, this guy's tailgating us all the way to the hospital. Just being an asshole. All right.
It's like the parents of the child. Like, get these motherfuckers out here.
So we want to go ahead and use our sirens, right, as we're going code 3. We don't always have to. There's certain situations where we don't, but for the most part, okay, lights and sirens are going to be used whenever you go code 3. We have a PA system, okay, so we have a loudspeaker where we can talk, okay, but use that responsibly.
Move, motherfuckers! People are dying here!
Do not play Taylor Swift over the PA like one of my partners did. We're going back to station, so.
End of the night, we gotta stay awake, you know.
Yeah, have some fun. It's fine. All right, you can do that. You used to be able to do that. Now there's super monitor and stuff like that. So he also yelled at a kid that like jaywalked. He's a flight medic now too. So.
Oh, that's cool.
As far as cushion of safety, right? We want to make sure again we have that distance. Okay, these ambulances are pretty heavy. Okay, so again they don't handle like your Honda Civic where it stops on a dime.
I don't have to worry about myself.
Okay, so you just want to make sure that we have enough distance between other people. Again, that's why we do not tailgate. Okay, constantly scan your blind spots. Okay, because ambulances have some pretty big blind spots where cars can be, pedestrians can be, things like that. Okay, as far as backing, you always want to use a spotter. Okay, and some companies, right, will automatically fire you if you hit something while you're backing up without using a spotter. Okay, so it's automatic termination. Doesn't matter if you have a little tiny scratch in the bumper. You hit something, don't use a spotter. Even if you don't hit something and somebody sees you not using a spotter, again, they can fire you right then and there.
Can you say you use a spotter? Like, oh man.
A lot of, again, back in the day when I was working, you can get away with a lot of stuff. Nowadays you can't because they have cameras, they have tracking systems. Some ambulances have buttons on the back, on the outside you have to hit, right? That'll say that you have somebody in the back spotting you.
Well, they have cameras on them, review cameras.
Because they just don't want to.
So they don't have free cameras.
Right.
That's lame.
Yeah. So as far as you being in the back, again, you just have to spot and then just hope that your partner doesn't hit something that way, right? Or you may have somebody else, the fire, law enforcement, they'll act as your spotter, and that's fine. All right. So when it comes to excessive speed, again, does that save lives?
No.
No. Okay. So drive within reason. When we get to go code 3, it does not become the Autobahn out there. Okay. So we can only drive a certain limit past the actual speed limit itself. Most places say it's about 15 miles an hour above the posted speed limit.
What?
I use my
That's
own
all?
car.
Yes.
I do that on a normal day.
That's what I do.
I know, I'm just like, okay, well,
The time
they
stream
flow of
method.
traffic, because Californians don't drive by speed limit, they drive by flow of traffic. Everyone's going like 80, I'm pulling up at like 100, just zooming.
I didn't hear that, sir.
I wrote it down and tapped
They
it.
do. They do reference checks too. So. Oh, Holden
Really?
Fox. Yeah, he's a speeder. So.
Fucking, wow.
It's only for you though. You're the only
I'm
one that's
gonna put like the SWAT theme song music on and just cruising.
So, as far as that, yeah. So again, it depends on policy too, right? But most of the time, it's 15 miles an hour above the posted speed limit. Okay, we'll talk about going through intersections, things like that too. As far as crashes, okay, a lot of times it happens at intersections. We'll see that slide a little bit later on too. Okay, but intersections are the most common place where we are going to get involved in accidents. Okay. As far as crashes, again, spotters, we got to use them whenever we back up. again, you may be fired right off the bat without using a spotter, even if you don't hit anything. Okay, essentially, what they don't want you to do is cost the company money by hitting the bumper, because now they got to fix that. All right, they take that ambulance out of service, all that kind of stuff. So when it comes to making turns, okay, because the ambulances are very, very top heavy, do you want to take really sharp turns?
No.
What's going to happen? It's going to roll over. Okay, so take it slow, take it kind of wide, right, and then you can accelerate once you go out of that turn. Okay, try to slow down a little bit, turn, and then speed up. Okay, as far as hazardous road conditions, we don't have to worry about it too much here, thankfully. Okay, but in other places, right, where you have to worry about snow and ice and all that kind of stuff, obviously we got to take that stuff into consideration. Okay, obviously we have those really, really bad rainy days where you have 1.5 inches of water on the roads, right, where nobody knows how to drive. Okay, we do at least have the risk of hydroplaning. Okay, where you lose control over that surface of water. All right, so you just want to take it slower there. Okay, we don't ever drive faster than what's going to be safe for us to handle. Okay, which is a general driving safety rule. Okay, all right. So as far as laws and regulations, again, just because we're going code 3 doesn't mean we get to disregard everything, right? Just because we can.
You can't park in red.
No,
It's a fire lane. Are we
yeah,
fired?
not unless we're on a call.
Oh,
That's what.
Yes. Excuse me. If we're on a call, then we can park in the fire lane.
Oh, for lunch.
No. Okay, same thing for going code 3, right? We don't go code 3 just because, right? There's certain conditions in which we have to do that, right? So, as far as going through intersections, okay, it's usually based on policy as to what we're going to do as we go through that intersection. Okay, if it's a red light, okay, again, sometimes we can go through it, but we have to slow down, right? So some places say you can go through without stopping, but you got to slow down to 15 miles an hour or less. Okay, we can go through that way. Some say we treat it like stop sign. So we go to the intersection, we stop, we clear it, and then we go from there. Right? Some other places say we clear it lane by lane for opposing traffic. So let's say, for example, we have 2 lanes going each way for a grand total of 4 going through the intersections. We stop at each and every one of those lanes and then go through from there. Okay? The reason why they make us do that stuff is because most crashes occur where?
Intersections.
At intersections. And the most fatal type of crash is what type of crash?
T-bone.
T-bones or lateral crashes, where we tend to see a lot of that stuff. Okay. As far as driving, again, faster than speed limit, within reason, driving against the flow of traffic, driving on the wrong side, usually that's a last resort. So as you pull into that intersection, all lanes are blocked, then you might be able to go around, but again, you want to go back onto your same lane of traffic. Okay. It's not like GTA where you can just drive on the wrong side of the road just because you can. Okay, because a head-on collision is a lot worse than any other type of collision besides T-bones.
Oh, my question is, are there any ambulances that are decked out with the switch? Because certain, I know, fire and paramedics have switches to turn red lights, green lights.
No,
You don't have
not
those?
most. Nope. All right. So as far as certain laws that we cannot break are common sense. Okay. So one of them is what we do if we go to a school bus, right, that has a stop sign out. Okay. If we come up to a school bus that's unloading kids with a stop sign out, we cannot go past it because kids are dumb. Okay. Where they will just run right out of that school bus, right, cross the street. Okay, and they're going to be completely oblivious to that because kids are dumb. Okay, so we have to wait until all the kids have been unloaded, or the school bus driver says, "Hey, get in here, close the doors, close this," and then we can go from there. Okay, so again, we can't go that. We can't speed in school zones. Okay, if children are present.
Oh.
Okay, so if there's any kids around a school zone, we cannot speed in that area. We have to go the posted speed limit. And when it comes to a railroad crossing with the dividers down, who's going to win, train or ambulance? Train. Okay. So, right, we go ahead and we wait, right, while those dividers are down, right, and we just notify dispatch. Hey, dispatch, we're at train delay, right? That way, dispatch goes, ah, shit, okay, right, and then we just wait, or they cancel us and reassign another ambulance.
What if it happens when patients are back?
We're at train delay.
RIP.
Big deal.
Turn around.
Right.
Take my
Yep. Yeah, just stay there. All right.
I don't want to train.
As far as the sirens, okay, there is thing known as siren syndrome, where people start to tune out sirens, or they simply don't hear it. Okay, so lights and sirens must be on. That way, at the very least, if they can't hear the sirens, they might be able to see the lights. And again, with most modern lights, they are pretty dang bright. Okay, so if you have a long stretch of road, you can see an ambulance coming from pretty far away. All right. The most dangerous places are, again, at intersections, okay, because they may not see us and or hear us, right, as they're going through. Okay. As far as right-of-way privileges, when we're going lights and sirens, okay, we're actually requesting the right-of-way from other drivers. Okay, we're not demanding it, we are requesting it. But legally, they have to give it to us anyways, right? So it's kind of one of those things where, yeah, it's kind of a courtesy thing, but they're also mandated to do that. Okay, so we just have to keep that in mind. And of course, do people always know what to do when there's lights and sirens?
No.
No. Okay, so obviously they're supposed to pull over to the right. Okay, let us pass and then go from there, right? Or if we're opposing, stop where they are. But of course, you'll have those people that will stop right in front of us, or that'll go to the left instead of the right in front of us.
If they stop right in front of us, that's when we use the speaker?
Yeah, tell them pull to the right.
Speaker, does law enforcement appreciate when we play the cops intro when they show up? Or?
No, it's probably the one thing that pisses them off.
Question, is the loudspeaker audio being recorded like AVs?
Probably. Like I said, nowadays you can't get away with a lot of things, right? So back in my day you could, and then even before that you could do a lot. So I've heard stories from people that have been doing this like since the 80s, right, of what they used to do and could not get away with even thinking that stuff nowadays. So
What did Vince do?
I didn't do anything. So as far as intersection hazards, again, intersections are the most dangerous places where we're going to be getting to a lot of crashes. Okay, again, a lot of T-bone crashes where either we T-bone somebody, which is usually worse because our EMSs are heavy, or if they T-bone us, if we're transporting, that's really bad because we don't have a lot of protection in the passenger compartment. Okay, in the patient compartment rather. All right.
Two questions. One, say law enforcement does show up on scene. How often do they transport us, like to the hospital?
Escort?
Yeah.
It depends on if they write a 5150. The officer who writes it has to transport with us, so they may have an escort go and follow us. Or if they tase somebody, they have to go with them, right? Or if it's a dangerous area, then they'll escort as well, right? So as far as intersections, we got to worry about that. Okay, like escorts, same deal, right? If we're going to dangerous places, they may need to do that. Or if we're going to places like gated communities where it's a little bit more complex, security, right, will be able to escort us to the actual location, things like that. When it comes to highways, okay, or freeways, as we're getting on the on-ramp, we're going to go ahead and turn off our lights and sirens. Okay, we're going to start making our way all the way to the left, and once we're all the way to the left, then we light it up. Okay, and the reason why we do that is, again, when there's lights and sirens, driver is supposed to go to the right. So as I'm coming on and I have my sirens on, we crash. Okay, so you turn it off, make your way all the way to the left, light it up. That way everyone starts pulling out of your way. Yes?
Oh, wait, hold on. I was trying to get that.
Okay, so once we are exiting, then again we shut it down, make our way to the exit. Once we're on the off ramp, then we light it back up again. Okay, as far as unpaved roads, obviously drive as safe as you can, right? As fast as you can, but as fast as safely possible. Let me rephrase that. Right. So we want to make sure that we have a nice good grip because again, obviously the ambulance will be rocking around a little bit. School zones, again, unlawful to speed in school zones while children are present. All right, so when it comes to minimizing distractions, straightforward. You should not be on your phone while you're driving an ambulance, period. Okay, especially if you're transporting patients. Okay, as far as eating, do it when you can. Okay, probably not best to eat your sandwich as you're driving code 3, taking the patient in the back. Okay, as far as that kind of stuff, just do it when it's safe. If we're parked, who cares? Okay, when it comes to using the radio, right, if we have a patient in the back, turn it down. Okay, but if you're driving code 3 to the call, choose your favorite code 3 playlist and go from there. All right. As far as the passenger, while they're in the front, they can again provide navigation. They can act as a secondary spotter where they're checking out things, clearing intersections, right? So your partner, right, if you're navigating, you'll yell, all right, we're clear right, and then driver will look for their area. That way we know that area is secured, right? And then they can just keep going from there. Makes our driver's job easier. When it comes to air medical, right, we have our helicopters, right, as well as fixed wing aircraft. Okay, as far as fixed wing, okay, we're not going to be using that very often. That's going to be just for super duper long transports. Okay, but we may call for helicopter transport. All right, and depending on where we are, we may be using this fairly frequently or relatively infrequently. So when it comes to calling for medevac, okay, really it comes down to time and or distance. Okay, in more rural areas, right, we may have hundreds of miles to the nearest hospital or trauma center or anything like that. So that can be, an hour or two via ground transport, or maybe 20 minutes with a helicopter. Okay, so that may be an instance where we call for a helicopter to fly them out to certain places. Okay, time is obviously the other factor too. In LA, right, on a holiday weekend, on the 405, are we going anywhere anytime soon? No. Okay, so even though the hospital is only 4.5, 5 miles away, it's going to take us an hour and a half to get there, right? So we have to be like, hey, it sucks, but we got to go and fly them out those few miles because they're not going to make that time. Okay, so we have to call for that, right? Patients that require advanced care. So obviously we can only do so much, right? On the ground, paramedics can only do so much, but in the air, paramedics can do a lot more than a ground paramedic. Okay, there's also flight nurses who can obviously do a lot more as well. Okay, so we have to determine, all right, does the patient need a certain level of care that we can't provide on the ground? Okay, when it comes to patients who need it, usually it'll be trauma patients. Okay, because time is of the essence for trauma. We have to keep in mind what hour? Golden hour, right? So the time of onset of injury, illness, so the time of definitive care. We want to minimize that time as much as possible, hence why we need to fly them out. Certain medical patients may also need air transport. So patients who are having significant strokes, MIs, things like that, we may have to fly them out. All right, we want to go and call for that as soon as we possibly suspect the need for it. Okay, because they're not going to be sitting there in the helicopter the whole shift, be like, all right, let's go, and fly out. Okay, it can take them a half hour, 45 minutes to actually mobilize to start getting ready to go.
If it's just anything in 45 minutes to get there, it takes me like an hour to get to the place. We're not.
Again, we use our discretion. Or, again, if we get called out in a rural area, we get the call, hey, let's just get them on standby. That way they prep everything because it's that they just don't run out and go. They have to do maintenance and all that kind of stuff. So at least we have them on standby. Okay, yeah, we need you guys. Cool. That time's less and they can fly out from there. All right. So dispatch, again, should be notified, and they'll probably send them out to you if they need it. Right. So again, if it is a call that's going to be super duper in the middle of nowhere, they'll activate us and the flight medics. That way we can go and rendezvous and get there quickly. All right. So when it comes to establishing the landing zone, that's going to be our responsibility. Okay. Preferably a nice flat surface that's 100 by 100 feet square, with no overhead obstacles like power lines, light poles, anything like that. Okay. So it gives the helicopter plenty of space to land. Right, and gives us plenty of room to stand away from the area so we don't get hit by the rotor wash, any debris that's flying or anything like that. All right. If it's at night, okay, we want to mark the landing site with lights. So we can take our vehicles that are around, kind of park them in a square and turn those lights inward so they can see it from the ground. Okay, we're not going to use flares to light up the area because when the helicopter lands, it kicks up a lot of what? Dust, which is coming from a lot of wind. Right, from the rotors. Okay, so now you have a flare that's on fire that's rolling away, and that can cause a what? That can cause a fire. Okay, so we don't want to use flares to mark it. Again, we'll use lights, things like that.
Already there, probably.
Not always. All right. We don't want to use taper people because you can't see that from all the way up. Okay, so again, use something nice and large, like vehicles that are parked in certain locations. Okay, anybody that doesn't have to be there, doesn't have to be there, so just kick them out. Okay, that we have the least amount of people there possible. As far as approaching the helicopter, okay, we only do so when it's safe to do so. And the flight crew is going to tell us when it's safe to do so. Okay, so once they land, right, they'll come out, okay, they'll make sure it's safe, and then they'll start waving us to come to them. We'll go over the hand signals on the next slide, but it's pretty straightforward. Okay, now they may not shut down the helicopter completely, they'll just slow it down, right, which means that the blades may start to drop. Okay, and they can be as low as 4 feet off the ground, right? Not going to be all the way up to as high as they should be. Okay, and they may be spinning so fast that we can't what? See it. We can't see it. Okay, so again, we don't approach until it's safe to do so. Right, just like we know our ambulance inside and out, at least we should. Okay, the flight crew will know their helicopter inside and out, so they know the optimal routes of approach, which is the safest. All right, so don't lose your head. Okay, one way we don't approach is anywhere near the tail rotor. Okay, because usually they keep that spinning, and again, it's spinning so fast that you may not see it. So, like I said, my partner I used to work with, he's a flight medic. Right, he showed me a video of some guy that was being chased by the cops, and there was a helicopter around there for some reason. Walked right into tail rotor, just walking, pink mist and drop. Right? Yeah, exactly. All right, so don't lose your head. Right, we want to make sure that we are staying away from that, and again, the flight crew would tell us which way to go. So, again, very simple commands. If they want us to approach them, they'll do this. If they want us to go away, they'll do this. If they want you to stand up, they'll do this. They want you to crouch, they'll do this. They want you to go that way, they'll wave you this way. They want you to go that way, they wave you that way. Okay, so again, very simple commands, all right, as far as what they want to do. And again, we don't go until they give us the command to move. Okay, when they do show up, okay, we'll give them a brief report. They'll usually transfer them over to their equipment, and then they load up the patient, and then they fly away. Okay, we don't get to go with the patient.
Aww.
All right, you're too tall. All right.
Well, you say around 4 feet. I got real nervous. I'm like half my body.
Okay.
Crawl.
So they'll go ahead and get out of the patient, right, and they'll go from there. Okay, so again, super duper simple commands that they'll give us, and we don't approach until they say it's okay to do so. All right, now as far as landing on uneven ground, okay, you always want to approach from the downhill side, not the uphill side, all right, because we have more space here than I do over there. Okay, but again, we don't go until we're told by who? Flight crew. All right, so they'll tell us which way to go and when to go. Okay, again, at night, make sure we light it up, make sure it's obvious. Okay, do not shine any lights up at the pilots because they do wear night vision. Okay, so if you shine a flashlight at them, it turns off their night vision and then they can crash. Yeah. Okay, so just make sure we keep it down on the ground so they can see it. And again, if we have it lit up and they're wearing night visions, oh yeah, I can clearly see where we need to go. Okay, we can try to communicate with them as well, so we have to switch radio frequencies. So we can tell them, hey, we're over here, it's all clear, or hey, there is some branches that are coming out this way. Just be careful if you are approaching. Let them know about wind speed and direction if you can, right? So I think it's coming this way, right? That way they know how they have to compensate when they start to land. All right. If there's any type of hazmat, should the patient be deconned before they start flying out?
Yes.
Yeah.
Yes. Okay. Because again, they should be deconned before we even get to them, right? But if we are worried about multiple patients that we have to fly out, get the flight crew going, let hazmat do their thing. Once they're cleaned up, then they can go. Okay, because again, with cyanide, with its off-gassing, it may have a delayed evaporation, and it's bad if it's in an ambulance. It's worse if it's in a helicopter because everyone's going to be affected, and then what happens?
Helicopter crash.
They crash. Right? And as far as the frequency of medevac crashes, they're actually pretty common. Right? Probably about once a month or once every other month, there's a story of a helicopter that goes down. Right? So. But again, these are medical crashes, right? So it does happen quite a bit, and that's why they get paid the big bucks because it's basically hazard pay. Right? You're too tall.
I know. That's why I couldn't become Air Force.
So as far as that stuff, we do got to be careful of it. Okay, make sure it is decon. That's all. All right, guys. Be back at 8 o'clock.
Pretty much all I heard during that driving course is that I need to get out of my way. I will run them over.
Were you here for this? Or
Training too.
Like John's
Yeah. So when it comes to our equipment, we're going to be having some form of PPE, which again is personal protective equipment, which keeps us from getting hurt. Okay, so our turnout gear, right, puncture-resistant, flame-resistant clothing that the fire department would wear. We're going to have work gloves, and we're going to be wearing BSI under those work gloves, right, because we may have to deal with patients right there. So obviously we don't want their blood or whatever to seep through the gloves and get onto us. We're going to need hearing protection because extrication is pretty loud. Okay, so we want to have that stuff. Fire extinguisher just in case if there's any type of sparks or anything like that. Now, as far as vehicle hazards, okay, whatever happened to them can happen to us. Not really accidents, but possible airbag deployment. Okay, so if the airbags have not gone off, we do have to be careful because they may have a delayed reaction and they can injure us. Okay, so we just want to go ahead and play it safe, right, and just use caution if we're going to be going to a vehicle where the airbags haven't deployed, if the vehicle even has airbags. Right?
just like disconnect the battery.
Usually that's what will happen. Right? So we just have to be mindful of that if it hasn't gone off yet. Okay, and if the airbags have gone off, okay, we want to go and take a look at the damage to the patient so we have an idea of what's going on, right? Secondary and tertiary impact injuries.
If they haven't deflated, can we call them to deflate?
What's up?
If they haven't deflated already, can we call them to deflate?
Yeah, that's fine. All right, as far as bumpers, okay, sometimes they are going to have hydraulics within them, and they may pressurize and spontaneously kind of pop out, right? And sometimes they become projectiles and they'll take out your shins. Okay, so we just have to kind of approach from the side, don't approach directly on, just in case those bumpers do release. As far as extrication, again, that is removal from entanglement or entrapment. Okay, so extrication is the removal from entanglement or entrapment. Then obviously we're going to need specialized equipment to get that patient out of being entangled or entrapped. Okay. Now, as far as entrapment, it just means that the patient has been pinned in some way, shape, or form, okay, where they're not able to self-extricate and get out by themselves. We'll talk about to do with situations like this where the vehicle's not on all four wheels on flat ground. Okay, but do we have to worry about safety issues here?
Yes.
Yeah. Okay, especially that car rolling, right, and smashing that guy right there, maybe pinning this dude and this dude underneath as well. Okay, so we do have to be careful of those things, and we want to try to stabilize the best we can. So, different phases of extrication. Again, very similar to our phase of an ambulance call, but dealing with extrication. So, the prep phase is pretty much the same. We'll get to those in a bit. All right, but we want to make sure everything's good to go. As far as our job as EMS, we're there to treat our patients. Okay, and sometimes we have to go into the vehicle while they are doing extrication. Okay, so sometimes we have to go in while they're providing extrication. And we may have to do things like C-spine immobilization, right? Any airway breathing circulation treatments. Right, and they'll typically send the smallest person in there since they're going to be the ones who actually get in there. Yeah. Right. Finally, being freakishly tall will help you. So,
What about a fight on-site?
what's that? So, as far as the extrication team, again, they're responsible for actually pulling the patients out. Okay, they may also stabilize the area. Law enforcement, again, is going to go and control traffic, and the firefighters are there just for fire suppression. Okay, so we have to call resources as needed depending on whatever situation we got. So, prep phase, same as our prep phase for an ambulance call. We're going to go through, just make sure all of our extrication equipment's good to go. Okay, make sure we have everything checked out. En route to the scene, same deal. Okay, just go ahead and get over there. We'll go ahead and just notify our dispatch, right, that we are there. Arrival on scene. Okay, we want to go and do a complete walkabout of the actual accident itself to assess the mechanism of injury. Okay, so we can go ahead and take a look to see if there's any damage to the rear of the vehicle, front of the vehicle, anything like that. In the case of ejections, we want to see if there's anyone around the vehicle that's been thrown out. Okay, we also want to look for any safety hazards. So see if there's any gases leaking from the back that we may not have seen from our initial angle of approach. Okay, again, is scene size up a one and done deal?
No.
It's what?
Continuous.
Continuous. All right, it's a continual process. Okay, so if we're working on a car and look, shoot, it kind of smells like gas, right? Now we have to start worrying about leaking gasoline. So, again, do our walk around, check the MOI, check for ejected patients, right? All the things we just covered right here. So, look at the actual damage to the vehicle. So, again, assess the mechanism of injury. Look for where the impact happened on the car. Look for airbag deployment or lack thereof. Okay, any bent steering wheels, cracks in the windshield, right? Passenger space intrusion, skid marks behind the vehicle. Okay, any physical clues that we can observe to give us an idea of what might be happening on this call, right? And what may have happened to the patient. Right, of course, evaluate the need for additional resources based on whatever hazards we may come up against or things we may suspect. So because we're assuming we are extrication, right, we've already got that, but do we need to call for ALS? Do we need to call for fire? Do we need to call law enforcement, et cetera, et cetera, et cetera? As far as going into the car, like I said, we may have to go in while the extrication procedure is happening to provide care to the patient. Check for any type of environmental issues. Right, again, doing that whole continual scene size up. Communicate with other rescuers. Right, that way we know what's going on, especially once we are ready to move the patient out, which we'll get to in a little bit. Okay, and obviously communicate with the patient. Try to orient them as best as you possibly can so they know what's happening. So they may not be able to see exactly what's going on, or they just have no idea what's happening. So at least tell them what you're going to be doing. All right, when it comes to making the scene safe, if it's not safe already, it should be, we got to, of course, make it safe. If there are down power lines that are on the vehicle like we have here, do I just come walking up to it? No. Who do I need to call? Yeah, I need to call the utility company, have them shut down power in that area, make sure it's safe, and then we can go to that area. And until then, we're just going to hang out and just wait. Because obviously whatever happened to them can happen to us. Okay, and if we get fried, we're just another patient.
Kind of body at that point.
Still a patient until we're proved.
Can I wear just rubber boots?
No.
Just don't be grounded. It's fine.
So, when it comes to hazard control, we have to go ahead and stabilize the vehicle using what is known as cribbing. Okay. So you want to go ahead and put a bunch of different blocks and whatnot to help stabilize cars, so that way they don't roll. Okay. We can also take some blocks, place underneath the frame of the vehicle, pop the tires. That way it'll go ahead and actually lower onto that cribbing.
Who pays for that?
Insurance. Okay. Make sure the vehicle is in park as well. Okay, so shift it to park.
Neutral.
Yeah, and if the vehicle is a stick shift, okay, there's 3 pedals. One all the way to the left. You press, move the shifter over to the left and up, and now you're in first gear.
What?
Yeah. Because people don't know how to drive stick shift.
I don't.
Yeah, no, I know.
They suck. It sucks in traffic, but it's fun.
I can do it with a motorcycle, just can't do it with a car.
It's the same thing. It's just instead of this, it's
Y'all are
this.
ancient.
I don't know.
That's way too many things.
Motorcycle.
Motorcycle is just down to first and then up for the rest of them.
I just know cars.
Not for our age.
Not for LA because it's not worth driving.
No, it's not.
It's not.
Not even
So,
yeah.
as far as different forms of cribbing, there's different patterns that you can use for whatever. Obviously, we're not going to show you how to do that, but different places will train you on how to stabilize. Okay, with other vehicles, right? You know, with all electric cars being now a thing, right? Obviously, lots and lots of wires, so we got to be really careful. With hydrogen vehicles, we have to worry about hydrogen gas leaking because, of course, very, very flammable.
Hydrogen?
Yeah.
Yeah.
Like water cars?
No.
No, like hydrogen gas cars.
Yeah.
Like
Oh,
natural
I
gas.
think like hydrogen fusion, like
Like
water
the-
cars
it's
turning into. And I was like, what
The
the
Honda
fuck?
Ride or whatever it is.
Right.
Oh,
Hydrogen.
Yeah.
That's a shit.
Right?
That's not hydrogen coupling.
Anyways, so as far as support, alright, again, we may have to go and work with fire to go ahead and provide extrication, you know, lighting the scene and things like that. Okay, marking helicopter landing zones, setting up equipment. Okay, just doing anything to help out with the actual extrication and rescue process. Gaining access. All right, so now we get to the fun part. So as far as gaining access, we always try before we pry, or pry before we try, whatever it says there. Try before you pry. Okay, so basically try the door handles. Okay, see if the door opens up. If the driver's side door doesn't open up, then I try the door behind the driver door. Okay, if that doesn't work, go around and try the passenger side doors. Okay, if none of those doors open so we can't get inside, then we go breaky, smashy, smashy, and get into the car. Okay, but we always want to try to go with the least invasive to the
Most
invasive. Okay, so again, even though fire just likes to peel apart cars anyways, okay, we have to go and try before we pry. All right, so try the door, okay, and then we go ahead and go from there. All right, again, we don't want to break any glass if we don't have to, okay, at least near the patient, because now we got to worry about lacerations from the broken glass, okay, as we do that stuff.
Most cars have safety glass now, don't they?
What's up?
Most cars have safety glass that
Newer ones.
minimize.
Newer ones, yeah, my truck doesn't.
Yeah.
So we want to go ahead and just try to do that kind of stuff. All right. So when it comes to consideration, right, we have to make sure that the patient is entangled in something. See if they are, if they're not. Okay. Were they ejected? Okay. How damaged is it? So we're going to go and take a look and see what we have. Right. So here we have different forms of cribbing. So they have some basically 2x4s, right underneath there. So they got it underneath the frame, and then what they probably should do is pop those tires so the car sinks. Right, and now that weight's supported on the cribbing. All right, they also have some blocks underneath to chalk the wheel so that way the car doesn't roll backwards. Okay, so look for any hazards present. So with damage to the engine compartment, we may have to worry about leaking fluids. Okay, could the engine be hot?
Yes.
Yes.
Yeah, most fluids in engines tend to be flammable, so we do have to worry about that risk. Okay, look at the position of the vehicle. So here, we happen to be on all fours. Okay, it's not too bad, right? But if the car is on its side or upside down, all right, it may not be as stable. Okay, what kind of surface is it on, right? And is it apt to roll or tip over depending on, again, where the actual placement of the vehicle is. All right. So when it comes to rapid extrication, okay, if we have to rapidly extricate, or as Matt likes to say, yoink, okay, if we have to go and provide rapid extrication, okay, we have to do that for patients who are critical. Okay, so patients are unstable or the scene is unsafe. Okay. The patient's unstable, so they're critical, or the scene is unsafe, then we have to go and provide rapid extrication, aka
yoink.
Right.
How many times do I yoink the patient before I just dip? Like if the car engine starts going to fire, do I just like
Once.
quick tug and dip?
Once. Yeah, we get one shot to pull that patient out to safety, just like we talked about way back in patient assessment. Okay, so if they're pinned and I can't yoink them out, okay, are we going to burn next to the patient? No. Yeah, good luck. Right, and we run.
Just let them know.
Okay, so we want to go and try to do that. All right, so here we have a patient, right, who's got cracked in the windshield, appears to be unconscious. Is this a yoink indication?
Yes.
Yeah.
She's got she's
Yeah,
knocked out.
patient's unstable. Okay, now we want to try to maintain C-spine mobilization as best we can, but sometimes we have to just get them out of there, all right, so we can start providing treatment. Also, if she's blocking somebody that's more critical, okay, even if she were stable, yoink, get out of the way so we can get to the more critical patient. Okay, but usually, again, if the scene's unsafe or the patient's unstable, then we provide extrication. Now, as far as complex access, so this is where we have to use tools. Where simple access is try before you pry. If I can open up the door, right, and get to my patient, cool, we're all set and ready to go. But if we have to use the jaws of life to cut them out, now that's complex access. All right, and when we're doing that stuff, again, very, very loud. So if we have spare hearing protection, put it on the patient. Okay, we may also want to use some flame-resistant blankets to go and put over the patient to reduce them from getting any burns. Okay, also helps protect them from any sharp metal, broken glass, things like that. Okay, again, explain to the patient, tell them what's going on. Tell them, hey, it's going to get really loud. All right, so we're going to put these earmuffs on you. We're going to try to cut you out so that we can free your leg. All right, we'll get you on the backboard and get you out of here. All right, so that way the patient's aware of what's going on. All right, not freaking out more than they need to. All right, as far as providing treatment, like it says here, just do your job. Okay, so it says airway, breathing, circulation. Okay, take care of any of those treatments that we can while the patient's in the vehicle. All right, if we can, go ahead and strap them to a backboard, right, or KED, which we'll get to in just a bit, and then prepare for transport. So nothing much more out of the way than what we've already talked about so far. As far as removal of the patient, okay, if we have to, then we can go ahead and cut apart the vehicle, just yank them out, all right, all part of that extrication process. Okay, whenever we have any type of move, when we're moving somebody, we always need to have preparatory commands as well as lifting commands. Okay, and we've already kind of covered that a little bit in spinal, right? When you're ready to roll, you're making eye contact. Hey, head person, are you ready? Leg person, are you ready? Okay, we're going to roll on 3. That's a preparatory command. 1, 2, 3, and then we have our lift or move command. Okay, we want to have that whenever we're moving patients, okay, including extrication. And we'll talk about that when we get to lifting and moving patients, all right, for the last chapter. So, when it comes to the transfer phase, now we're getting the patient out of the vehicle onto the stretcher to get him out of the hospital, or get him out to the hospital. All right, and we want to do it in a series of controlled steps. Again, lifting and preparatory commands. Now, as far as this patient, can anybody tell me what is wrong with this picture here?
The head is not stabilized?
It's a different way of stabilizing, so they're coming down from the
Oh,
top like
okay.
this.
Can't even tell what we're looking at. Is she like?
She
past the
folded?
windshield?
No.
Okay.
Is it wearing so?
And if the firefighter isn't wearing sterile gloves?
They're probably wearing stuff after that, or underneath that.
Is it oxygen?
He didn't check CMS.
Probably. I wouldn't doubt it. But no, that's not it.
Her spine isn't stable?
Again, it's a different
Oh.
way of stabilizing since we're coming down like that.
Is it because there's maybe blood going? I mean, I don't know.
Do you see any blood?
No,
Yeah,
internal
right
blood
there.
going down, gravity away. Nah.
She's bleeding, right?
No, she's not.
On the left shoulder, that's not blood?
No, it's her jacket.
Oh, I see.
Oh.
still
Yeah,
don't see
that chin flap, okay, that's supposed to be underneath the chin,
What is it?
right, is pressed into the patient's trachea,
Oh.
right, which could be collapsing the airway.
Wow.
Oh, okay.
Yeah.
She has such good breathing. It's fine.
Well, again, we don't know that. Maybe that's why she's unconscious, huh?
Can you check the pulse after you put your thing on?
We don't have
on
to.
the neck?
We don't have to.
Okay, because I got yelled at.
Okay.
I just like to yell this.
He likes yelling at me.
All right. So we need to make sure that chin flap is deployed. Now, again, in this picture, okay, maybe it's not a big deal. Like usually, female patients need the pediatric collar anyway, so she probably has room for that, and that's fine. All right. But if you were to put on a patient who's got a bigger neck, that's going to be going right into their Adam's apple, right, and that could choke them out. Okay. Now, with the collars that we have, right, as long as you don't have your hands over the top, that chin flap will automatically pop out. Okay. But this type of collar is pretty much the same brand that we use for the peds, where you have to manually pop that one out. Okay. So, as far as termination of the extrication process, everything's all done. We wrap everything up and we make sure it's good to go for the next call where we repeat all the stuff we just covered. All right, so we'll go ahead and restock everything, fill out all paperwork necessary, and that's it. Now, as far as special teams, okay, again, we are trained in EMS, but also cross-trained with other different things. Okay, so yes, you can use your EMT and go do different things, right, as long as you have additional training to do it. Okay, so just some examples, right? Cave rescue, usually along with confined space, such as diving rescues and all that kind of crap, right? Working out on like ski patrol, okay, out in the mountains, doing search and rescue teams, things like that. Structural collapse, trench rescue, right? Working on SWAT. Again, there's a lot of different things you can do with your EMT as long as you get the additional training and certifications, right? Then you can go ahead and use that for a lot of other stuff. When it comes to search and rescue, okay, we may be out on the actual rescue team to go out and find the patient. And if we do find somebody out in the snow, what's the first thing we want to try to do?
Move them out of the side.
Get them out of the environment. Okay, try to warm that patient up and then start bringing them back to camp. Or we can just be stationed at camp, wait for them to come back to us, and then we start doing our treatments. Okay, now as far as resuscitation, for these patients, they're not dead until they are warm and dead. Okay, and we just do everything up until then. All right, when it comes to trench rescue and confined space rescue, okay, we have to be really careful about things collapsing in on us, because obviously whatever happened to them can happen to us. Now, if you are called to, some type of, collapse of mines or sinkholes or anything like that, okay, you don't want to park your ambulance directly on top of it because that ground's probably not stable. Okay, so you want to park at least 500 feet away from the incident site and hope that that ground is still stable enough. Okay, so tread carefully, right, as we are walking over there, right, and we want to make sure we're not going into anything that's not secured with any type of post up against the wall. Okay.
The other number for parking safety, instead of 100?
For traffic accidents.
100 feet or?
100 feet. Yeah. All right. So as far as working on SWAT team as a medic, most places you have to be at least paramedic. Right. Others, right, could just be EMTs. All right. So this depends on the incident. So we'll be going, obviously, being law enforcement as our primary function, and then afterwards, then we go and start providing medical care to whoever needs it. Yeah. So we make holes and sometimes plug them. Just depends. All right. So as far as structure fires, okay, we'll be standing in the rehab area, right, waiting for any firefighters to come to us with any type of smoke inhalation injuries, burns, other musculoskeletal injuries, or again, we may be just doing triage or treatment or transport, right, in the case of large ginormous structure fires with multiple patients. All right, so we'll just hang out, do whatever we have to do, right, and sometimes there's nothing at all, so we just get to watch the show and then go run another call later on for ground who fell. All right, so that's it.
That's it for the night?
Wow.
He said it's mostly the same stuff. All right. Last new chapter of information.
Wow.
So,
I've
lifting and moving patients.
Or no.
Yeah. Sooner than you thought. All right, so lifting and moving patients. All right, so obviously our job is to provide patient care, but also to move patients from point A to point B using different techniques and whatnot. So we have to make sure that we're using the proper technique, okay, for whatever situation we come up against. Okay, making sure that we don't obviously hurt the patient, but also don't hurt who? Ourselves, especially back injuries. Okay, so we have to make sure that we're using those proper lifting techniques, which means, do you snap up with your back? No. Okay, you lift with your legs. All right, so make sure you're practicing using your equipment. Most of it's pretty straightforward for the most part. All right, but we do have to try to be proficient with it so we don't cause harm to patients or ourselves. So with geriatrics, okay, do they always want to go to the hospital?
No.
No, because they think they're going there to
Die.
Okay, we could also exacerbate different types of injuries by using improper lifting and moving techniques. Okay, since they have more brittle bones, their skin's a lot thinner, more easily torn. okay, they're going to have conditions like kyphosis, which again is that hunched over spine, okay, where they're not going to be secured flat on the backboard, hence why we have to take pillows and fill in the void space, chiefly behind their what? Head. Okay. Pressure ulcers are a big deal with geriatrics as well. Right? Again, can start happening after just a couple of hours of staying in one spot without being shifted around. Okay. So with kyphosis, that's what we see. So again, if that backboard were coming straight across here, right, I need to fill in this void space using towels or pillows or whatever we have, because again, I'm not going to take them and wrench them back down like that. Okay. So when it comes to a bariatric, okay, that is the medical term for a patient who is a little overweight.
Little.
Right. So as far as bariatrics, okay, are we going to be dealing with quite a few of them?
Oh, yes.
Yes. Okay, so we have to make sure that we are using, again, proper lifting techniques, lifting with our legs, not with our backs. Okay, if the patient's too heavy, okay, who do we have to call?
Ghostbusters.
No. What are they going to do? Who do we have to call?
A stronger.
Call for other people.
Yeah.
Okay, you call for a lift assist.
Can we, if I'm 40 and certified, would that work?
No.
Can we bring,
Like support belts.
yeah, because like I use it to like lift.
Yeah,
Can I
that's
just
totally
bring
fine.
in my like rig and have it for big patients?
You could. He'll laugh at you, but yeah.
Hey, I'm just gonna laugh at that. When I get my big, I'm gonna stab it up real quick.
Yeah, no, that's totally fine. Right, whatever you got to do to save your back, totally fine. Okay, and there's no shame in calling for a lift assist either, within reason. If your patient's 120 pounds, don't call for a lift assist. Okay. Right. But again, if you got patients, usually about 250 is where we start determining that we need to call for a lift assist.
Children?
What?
So,
Overweight children?
250 children?
no, kids aren't.
Oh,
No. All right. Now, as far as the stretchers, okay, the standard stretchers are rated to hold a lot. All right. So that stretcher right there can hold about 500 pounds, and that's just a regular stretcher. And 500 pounds, as it is, that's a whole lot of person. Okay. But these bariatric stretchers, right, they can hold up to about 900 pounds. All right. They usually can't fit on the stretcher, right, but the stretcher is able to at least hold that amount of weight.
Is there ever a time where we're gonna need a stretcher that carries that much weight?
Mm-hmm. Yeah.
Bring out
What, like people that just never leave their house and
Yep.
eat
Yeah.
diabetes all the
Biggest
time?
patient I had was 650. Right.
What?
Damn!
Yeah.
Did he just did his back like heat up the stretcher? Like he just walked around
Well,
it?
with him,
What the fuck?
we actually never transported because we couldn't get him out. There's no way for us to actually get him out.
Is that what you call fire? They ask.
Do you call
We called fire.
So,
So, so as far as the call, he was just sick. He just had a fever. Yeah.
Oh, I thought
God, good for him. Good for him.
Like no.
Yeah. No, it wasn't like a life-threatening call. Otherwise, we would have to like literally break down the wall to get him out.
Oh, shit.
But yeah, he was in the back room of the house. There was a back door that had pretty much walked out, and if I had taken one more step, I would have gone out because it was a sharp 90-degree turn. So we weren't going to be able to do that with the stretcher. The hallway was probably about this wide, and again, he wouldn't have been able to fit. Okay, so the only way to get him out would have been to literally break down walls to move him out.
That's honestly kind of
Right?
impressive.
Or just like what's eating Gilbert Grape, where you have to lift up the roof and then bring him out that way. Which, right?
It's an hospital.
Yeah. So when he saw like, okay, how are we gonna move this guy? And there was 8 of us there, and we still were like, how are we gonna do this? Right? He's like, yeah, it's okay.
That's when you get a dollar.
Right.
Hope for the best.
Yeah. So I mean, we felt bad because he obviously knew that he was not going to be going out of there. So we're like, you sure? Like, we'll try to work. So he's like, no, it's okay. I just have a fever and I'm fine.
Aww.
So that one did suck. Right. Now, with the bariatric stretchers, okay, they're going to have maybe like an extra 1.5 inches total width, which again doesn't do anything. But a little bit extra width. Sometimes the handrails here will actually be solid things that will kind of slant outward to kind of help hold more of the patient in. They're going to have extended handrails so we can get better position instead of having to lift all the way down or whatnot. Okay. And a lot of times they're going to have electric motors, okay, to actually lift and lower the gurney itself. Okay. We have to still probably lift it up as we're loading in, right? But at least we don't have to worry about bringing it up or dropping it down. So as far as lifting the stretcher, if we're loading it, okay, we have to pretty much go ahead and bring it up. Now, in most of our job, there's really not a whole lot of upper body strength compared to lower and core strength. Okay, so you most definitely don't want to be skipping leg day, right? As we're doing this kind of stuff, since again we do most of our lifting with our what?
Legs.
Right? We just curl just a little bit when it comes to loading patients and moving up. Okay. Now, as far as bringing the gurney up, we'll talk about how to do that, but we need to go ahead and go from the legs being extended out to collapsing up and then bringing back in. Okay. So we'll go just a little bit over gurney ops. We'll have some time to do it. All right. But you have to know how your gurney works. So as far as weight distribution, where is the heaviest part of the body? Top half or lower half?
Top half.
Top half. Right? Obviously, most of the body weight is going to be on the top half of the body. Therefore, the bigger, stronger EMT should be at the top half. Okay? So, they'll be taking care of the top half, right? Smaller one's going to be down by the legs. Okay? Make sure you're using the power grip. Okay? So palms are always facing up, never down. Okay? Because if I were to lose grip, at least I have more control like this, whereas here I go, oops, right? And they're going to go down at 9.8 meters per second squared. Okay, so
they're going to go down at this speed.
They will accelerate, yes, but still they will be moving down fast. So, as far as that, we want to make sure that we're not dropping patients because that's a huge, big lawsuit that we don't have to deal with.
Not if they don't survive. Yeah, if they don't remember, don't survive. Man.
No, it's even worse because there actually was an ambulance company I was working that killed a patient by dropping them on their head.
Oh shit! Who sued them?
The family.
The family.
What if they don't have a family?
Then you got lucky.
You won.
But
I got for those.
yeah, they still have friends and whatnot.
I don't think.
And the city can just
ever lucky.
No.
Like, ever.
So you can tell that's a Matt slide, right? Because that's just dumbass. Okay. So again, if we're going to be doing something like this where we have to lift from the floor, okay, you want to go ahead and bring your gurney, collapse it pretty much as low as you can. Okay, and you're just going to go ahead and just squat all the way down, pick up, move to the gurney, and then we can lift everything up together as a whole. So it's going to be a multi-stage move, right? Instead of just lifting all the way up and putting there. Okay. So as far as the power lift, okay, want to go ahead and again keep our hands palms up, just about shoulder width apart, if not about 10 inches spaced out. Okay, keeping our back straight as we're going down. Again, lifting with our legs, right, as we're moving up. Okay, so there we have it. Again, power grip, palms facing up. Okay, we cannot stress that's enough. Palms facing up at all times. That again, if we do start losing our grip, we have more control instead of them just going down to the ground. Okay. As far as our prep and lift commands, like we were saying earlier, okay, we need to make sure we're having preparatory commands. Head, are you ready to move? Legs, you're ready to move. Okay, we're going to move on 3. All right, 1, 2, 3, and then we move. Okay, make sure you're making eye contact as well.
With the patient or your partner?
With the partner. Okay. 1, 2, 3. Okay, tell the patient what you're going to do, but then make eye contact with your partner since you have to coordinate movements. And a little bit of eye contact goes a long way. Okay, and we see this all the time when you guys are doing crappy spinal rolls and you're doing this shit with your classmates. Like, look at your partner's eyes, right? And then for whatever reason, I'd say 80% of the time, it just becomes a nice, perfect log roll right after that. Okay, so just look at your partner. Hey, partner, we're going to go ahead and move them over on 3. You ready? 1, 2, 3, and then we move, and that's it. And depending on who you work with, you get to know each other enough to where, like, all right, cool, and then you just go. All right, you get your timing in sync and all that stuff. Okay, there should be one leader, so one person who's communicating, and that just depends on policy and stuff like that, and how you guys work with each other. Usually, the person at the torso is the one who's going to be calling the move because what's the heaviest part of the body? The torso, right? And the one who's going to be doing most of the work is going to be the one who's calling it out. Okay, so that's why in LA County, when we do a log roll, it's the person at the
middle
torso, right? Not the head person. Okay, but for DOT, it's the head person because they can see down the entire length of the patient. Okay, I prefer LA County's method because it makes more sense, right? They're going to be the ones who've got to put up the momentum to move the patient. Okay, so as far as bariatrics and our lift assist, okay, call for it if you need to. And like I said, usually about 250, right, is where we start, determining if we're going to need a lift assist or not. Okay, but you always try to lift to the best of your ability. All right, if you got a patient who's 175 and that's a little bit much for you, call for a lift assist. Okay, because if you hurt your back, are you good to anybody?
No.
No.
She looks so happy in that. She's like having the time of her life.
Because she doesn't have to lift herself. All right, so as far as this device here, it's called a Hoyer. It's just the brand name for it, right? But essentially it's a modified engine crane, right? Designed to hold patients. All right, so pretty much just go ahead and lift it up, right? And we can use that to move the patient. With this little sling here, we'll pretty much use that to move the patient. And then if we put it down the wheelchair, for example, we could use different ends here to lift and move and carry and do whatever else we have to do. Okay, obviously we don't have this in our ambulance, But if we were to have it available on scene, could you use it? Yeah, as long as we have people around who are trained in how to use it. Right? So we can go and use that to move our patients.
Well, I want one.
So as far as the stretcher, okay, sometimes called the gurney, sometimes called the cot. Okay, they will vary in weight. And the heavier the gurney is, typically the more secure, right, it is. So they can go anywhere from about 40 pounds to up to 145 pounds. And you have to keep in mind, that weight is also in addition to whatever the patient weighs. So if you've got a bariatric patient who's 400 pounds and you've got a 150-pound stretcher, how many pounds are you moving?
550.
550. Okay, and that's what you got to lift, roll, and do all that kind of stuff. Right, now, if they have an electrical system, that adds even more weight because they got to add in the motor, the battery, and all the other kind of stuff. Okay, so that can add on another 30 pounds on top of the weight of the stretcher.
Well, it's light work for me, Chris. You got that.
So we have to go ahead and just keep all that stuff in mind. Now, because of that, we really don't want to have to move the stretcher with the patient if we don't have to as far as lifting. Okay, if we got to roll it, so be it. Okay, they can do quite a few different things, right? So with the striker stretchers, in this case it's a rugged, those are pretty much the standard ones we tend to see. They don't really move around all that much. Okay, but there's other stretchers that the fire department has that can actually convert into a chair, right, as they roll around. So it just kind of depends on what you have, and of course the company that you work for will train you on their stretchers. So with the electric stretchers, again, it's going to add a little bit more weight, but we have that benefit of pressing a button, and it's going to go up by itself or go down. Okay, but because it's battery operated, what happens if those batteries die?
Sure as well.
No, we still do it, okay, because we're going to have manual overrides, but now we're lifting more dead weight on top of the patient. Right? So we can do that. A lot of companies nowadays, it's cheaper just to install these than it is to pay for workman's comp and all that other kind of stuff. But fortunately, right, now we're seeing a bit more of these electric stretchers out there. Right, but again, you're still going to have quite a bit of those good old-fashioned manpower, elbow-greased powered stretchers.
Real man.
So as far as the stretcher itself, okay, they are going to have wheels on the base, okay, and these wheels are like the ones on the shopping cart where they go wherever the hell they want.
Oh, fuck.
Okay, so because of that, you need to have at least 4 points of contact on the stretcher. Okay, that way we can steer it and have control of it. All right. Now with moving patients, I really don't like having it up all the way because it's very likely to do what? Tip over.
Do some Tokyo drift shit.
Okay. So lower it a little bit. We don't have to bring it all the way down on the floor because then we hurt our back as we're moving. But you may want to lower it just a little bit, whatever's comfortable for you and your partner, to be able to move the patient safely and stably as we want with at least 4 points of contact. Okay. If we have to stop, then one person can hold while someone, for example, is opening up the door or doing something like that. But as we're actually rolling the patient, especially when we're making turns or going over uneven surfaces, you need to have those 4 points of contact. Okay. Like I said, right, when I was in the field, okay, one patient, they were going down an alley, hit a pothole, and then patient went down head first, right, so all their body weight and the weight of the stretcher went and drove all that weight down to their head. All right, so they didn't die right away, but they died of a brain bleed just a little bit later. All right, so we have to be mindful of that kind of stuff, and there are plenty of videos you can find online of those people getting swung around and boom, getting slammed down.
What should I type in to look this up?
What not to do. Yeah. Okay. So we want to make sure we have that stuff firmly grasped. All right. As far as moving the patients, all right, just make sure we have the different people at certain spots. So as far as loading, okay, when we're loading up a patient, it's at minimum a 2-person job. Okay, we need to have one person at the feet who's going to go ahead and lift up and hold the stretcher. All right, and we're going to have somebody else to help collapse the legs to bring it in. So when we put the gurney in the back of the ambulance, it's going to be collapsed all the way, and we slide it in. All right, you can't really see it in these pictures, but right here, right at the entrance of the door, there's going to be a hook that's going to be in like this, and there's a little latch on the gurney that's going to catch that hook so it doesn't get pulled all the way out. All right. As far as the actual locking mechanisms on the gurney, we have a little post right here on the legs, and there's a little clamp just out of view here that's going to grab onto that and hold it so it doesn't go around in different places. And up in the passenger compartment, we have what I like to call antlers, okay, which is where the wheels that are going to be loaded up right there are going to lock into place. Okay, so we got a frame up front that's going to hold it, and then we have a little clamp on the side that's going to hold it, and that's it. Okay, and as we're loading in the patient, we want to make sure that those clamps are secure and that gurney's not going anywhere. All right, because as soon as we start driving, that patient's going to start moving all the way in the back. All right, only had that happen once, and thankfully we stopped like as soon as we moved. All right, but to make sure that doesn't happen, I would sit on the bench seat, put my foot on the frame of the gurney, so if it did move, at least I could kick it up against the wall to hold it up there while we can go ahead and fix it. Like I said, only happened once. All right, but you usually want to give it a little tug to make sure it's not going anywhere. All right, as far as the stair chair, great on paper, shitty in the field. All right, so as far as the purpose of the stair chair, it's to move patients up and down stairs. Okay. Now the reason why I say it's good on field and in paper is because we have handles on a chair, seat up in a phalanx position, we can move them. But usually, right, these are like little T-Rex handles where they come out right here, right? You don't really have much room. You're going to be pressed up against the chair, okay, and usually the patient. All right, there are some tracked versions that make it very easy to go downstairs, but not so easy to go upstairs. Okay, so we usually just have to lift these patients, and it takes a lot of coordination and communication, okay, to move your patients down safely without everyone going downstairs. All right, usually patients freak the hell out because it doesn't feel very secure. Right, so you also have to worry about them doing that stuff, right, tensing up as they're going down. You can't use this on unconscious patients because then they'll just, weaken at Bernie's and just lump over like that, right? So you want to go ahead and just make sure that those patients are conscious. Now, as far as the backboards, okay, backboards are not just immobilization devices; they're transport devices, and that's pretty much what we're using them for now, right? Instead of backboarding everybody just because they have spinal injuries, we can use them just to go from point A to point B. All right. Now, if we are going to use it just to move patients, we don't have to put the C-collar on and cheese blocked and all that kind of stuff. I can just use it to move them from point A to point B, but we still are going to want to strap down the body so they're not sliding around all over the place. All right. As far as the KED, okay, so the KED stands for Kendrick Extrication Device. Okay, so KED is Kendrick Extrication Device. And the KED is a brand name, whereas the generic name for this is the soft-seated spinal immobilization device. That's too many words.
Soft-seated
spinal immobilization device,
SSSI.
or the vest-type extrication device. Okay, but KED is pretty much synonymous, again, just like Narcan, and Kleenex, and Coke, and all the other kind of stuff. Right? KED just kind of is a catch-all phrase for these types of devices. Now, we use the KED for a patient who is stable and safe. Patient is what?
Stable and safe.
Patient is what?
Stable and safe.
Patient is what?
Stable and safe.
So can the patient be in shock?
No.
Because they're not what?
Stable.
Can the car be on fire?
No.
Why not?
They're not safe.
Right. Okay. But if the patient is stable and the scene is safe, right, and the mechanism of injury indicates spinal injury, then we can use the KED. Okay. So we want to go ahead and we get them all secured up. And we're going to show you guys how to use this tomorrow. Okay, so we'll show you guys how to use the KED tomorrow. Now, as far as splinting, okay, of course, we have to follow the rules of splinting. Okay, and as far as strapping order, the only splints that have specific strapping orders are the longboard and the KED. Okay, but any other splint that we apply, we can strap in any order that we choose. So for the longboard, of course, we start with the chest, and then we go to the
pelvis,
and then
femur,
and then
divot,
and then
head.
Okay, pretty much heaviest to lightest. With the KED, we have a different strapping order, and we have a phrase that we use to help you guys know the strapping order. That phrase is, "My baby looks hot tonight."
What?
Okay.
That's some
Pause.
sketchy stuff.
I didn't come up with it.
saying that.
My.
So, "My baby looks hot tonight."
Sounds like a trap here.
Okay. So again, that phrase is, "My baby looks hot tonight." Middle, bottom, legs, head, torso.
My baby looks
Hot tonight.
hot.
Middle, my, bottom, right, baby, legs, looks, head, hot, top, tonight. Okay, so middle, bottom, legs, head, torso.
Middle, bottom, legs, head.
Middle being pelvis.
Middle being the
bottom,
middle
legs,
strap,
head,
this one right here.
Oh.
Top.
Top or torso, either one. Right. So as far as middle, okay, that's referring to this middle strap here of the three. Bottom, legs, head, top/torso. Okay. Now once we have that patient secured in the KED, okay, we go ahead and check CIEMT. right? And then we get ready to extricate the patient out of the vehicle. Okay, so we have to lift that patient up or move him out, and then we still have to put him on a longboard. Okay, so we lay that patient down on a longboard, loosening up the leg straps so we don't pinch their junk. And then once we get them on that board, we strap them in again, going from heaviest to lightest. And then once I have them strapped down to the longboard, we got to check CMS. So when I'm using a KED and I'm mobilizing to a longboard, we have to check a CMS a minimum of how many times?
3 times.
3 times. Okay, we check it before, right? We go ahead and check it once you're secured to the KED, and then I do it again once you're actually secured to the longboard. Okay. Now, as far as the frequency in which we're going to be using the KED, we don't use it all that often, right? Because if the patient is stable and safe, do you think they're going to get themselves out of their own car?
Yes.
Usually, all right, which means they've already compromised their own spine, and we have to do another skill, which will be a standing takedown, which we're also going to show you guys how to do tomorrow.
Like, mobilize them, like, down.
Like similar.
Don't move your spine.
No, it's not an RKO out of nowhere. The patient will see it, but right, we're going to go ahead and move them to a different position. Okay, so we're not going to be using the KED very, very often. All right, but it is still a skill that we have to know how to use just in case we don't use it. So as far as the vacuum mattress, okay, this is what is going to be taking place of spinal mobilization instead of our longboard. All right, so we can use this to also move patients. This is pain in the butt to get them on. Pretty much confine them in there, and then we move them out. As far as the basket stretcher, so we can use this in cases of outdoor rescue and whatnot.
I asked you about Stokes basket. You said you didn't know
I don't know what Stokes is.
So that's it.
Okay, well then here it is. We don't use it, okay, unless we're part of search and rescue. All right. Okay, so if we are part of search and rescue, we'll go and load the patient up here, and then just pretty much use it like a sled and just drag them out of there, or airlift. Okay, with the scoop stretcher, right, that we're going to be using for patients who have some type of pelvic injury where we don't want to lift them around. Right, I've already pinched myself once really bad on this thing, so I'm not going to open it up. But okay, this thing is going to pretty much open up, and these things are going to quite literally scoop the patient up to get them on here. We close it up, and then I can move them and then place them onto a backboard or onto the gurney, and then unscoop it again. Right.
Oh.
So we're going to be using this instead of having to roll our patients right from one side to the next.
How would you check back lung sounds and all that stuff with the metal being there?
We won't.
So you just
Can't get it. Right, now keep in mind, the posterior and anterior lung sounds probably won't change all that much, right? So anterior lung sounds are generally good enough for us, right? So we can use that for patients. As far as the portable stretcher, aka the flat, that's what this thing is right here, right? So quite flimsy, right? But we can use this to move our patients, right? Same deal, we can go and use this to split out. We'll have to pull this tab out and then it breaks in half. Right, but very, very light, very portable, and we can use that to move our patients from point A to point B instead of using a backboard. Right, it's rigid, a little bit heavier. With the flexible stretcher, it's just a plastic sheet that will fold up, wrap the patient around, right, and then we can use that to airlift. Hopefully it's secured properly so the patient doesn't spin around at like 70 RPM.
you have to be able to hug out there?
Yeah.
That's so funny. So funny.
Patient's just sitting there. I'm sure the patient felt the same thing.
Oh, it was a huge loss.
Yeah,
So funny.
Yeah, I know.
But,
I saw that live. That
yeah.
shit was so funny.
So we may be able to put patients up on that again if we are part of search and rescue. Okay, so again, that requires a little bit more training. As far as the neonatal isolate, so we'll be using these to transport neonates, okay, and certain infants as well. Pretty much it's going to bolt onto the frame of our stretcher, and then we just go and transport. Yeah.
Will we ever really have to use these?
Not in the field.
Is this like from facility?
For IFTs, yeah. Yeah, usually these are critical care transports, so we're going to have a nurse or RT right, with us as we transport these patients. All right, as far as weight distribution, again, heavier side is going to be by the torso, so we want to have the bigger, stronger EMTs over there. Okay, and there's different methods we can use to carry patients. So we can use the diamond carry, which is what we have here, because if you're looking from the top down, they're in the shape of a diamond. Okay, so we'll have one person at the head, one person at the foot, and then 2 people by the side. Okay, and when we are moving patients, you always want to face the same direction. Okay, so everyone on the team should be facing the same way, and preferably the patient should be able to see where they're going to. So I just want to kind of go feet forward, that way they can kind of do that and look down.
What if they're... Oh, nice.
What's up? I mean, that's fine. All right, again, here, no C-collar, so they're just using this to move her out from point A to point B. So, as far as the diamond carry, we pretty much are going to go ahead and lift up from the ground. Right, everyone's going to turn, face the same direction, and that's where it sucks to be on the side, because then you go from lifting up like this to one hand, grabbing down like that, as we're all going to be facing the same direction. All right, so we just got to be careful with that. All right, person right here typically gets kicked in the butt, all right, as everyone's moving, but that's where we're going to be moving those patients. Okay, we can also do what I call the box carry, where everyone grabs a corner and we do the same thing, right? Same basic principles there. As far as carrying up and down stairs, again, we can use a stair chair if our patient is conscious, right, and they're able to hold themselves upright. Otherwise, we can use the backboard or some other flexible stretchers, right, to go ahead and get our patient down there. All right, now when we are going up or down stairs, okay, you always want to have the patient's head facing upstairs, feet going downstairs, okay, and make sure the strap's going under the patient's armpits, okay, because, right, gravity is a hell of a thing, and it will start dragging patients down, and if their shoulders aren't secured, whoop, the patient's going to go out and roll down the stairs, okay? So you want to make sure that you have them secured underneath there, that way that those arms are going to hold them in place, okay? As far as the stair chair, right, again, great on paper, sucks in practice. So we're going to go ahead and use this to move patients up and down stairs. So these are nice because they actually have extendable handles, but still, it's still pretty dang close. If those handles aren't there, you're pretty much right up in your patient's junk trying to go downstairs like that, right? If we can, we want to have a spotter there as well, right? That way they can go ahead and coordinate and see what's going on. Like I said, a lot of communication is required to do this effectively and safely and stress-free as we're going down. So when I would do the stair chair, I just tell my partner, okay, taking a step, 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 trying to keep things nice and consistent, right? And calling out whenever I move so my partner moves as well, right? Because if one person's pushing or pulling, okay, it throws off center of gravity, and then oops, everyone goes down the stairs, right? So we just have to be really careful with that. When it comes to the draw sheet method, this is going to be one of our common moves that we use. Moving patients from point A to point B, usually going from a bed or a chair to the stretcher or vice versa. Okay, it can be done with 2 people, but 4 is better. So to do this, the patient needs to have some type of sheet underneath them that can actually be used to support their weight as they move from one spot to the next. All right, so with this, we'd lift up on this side as well as that side, but these people tend to pull while the other people provide lift and don't really push much, but they kind of assist in that pull. All right, now if you are moving, whatever you're moving them onto should be a little bit lower than wherever you're moving them from. All right, that way use gravity to your advantage instead of having to lift up over the lip of the mattress on the gurney, right, and go down. Okay, so we can just slide up so we don't have to lift up all the way, bring them down onto the gurney safely. All right, as far as using the draw sheet, again, we want to use that. There's other devices too, where they basically use like a skid board. So they'll put it next to the patient, angle it down, and they just put them on and shoop, they just go sliding right in, kind of like bringing a boat into the water.
Oh.
All right, and then with that, we just pull it out, super duper easy. As far as other moves, we have the body drag. So use this to just move patients out to a place where you have more room to work. Okay, so for example, if we have patients who are in confined spaces, like the bathroom, okay, or they fell off the bed and they're wedged between the bed and the wall, okay, we just go and drag them out to an area where we have more space, and then we start doing our job. Okay, if we're worried about possible spinal injuries, we want to try to keep the spine intact as much as we possibly can, but otherwise, just move them out to an area where we have more room to work. For the direct carry, it's pretty much like the direct ground lift, just the difference is here's from the ground, here's from wherever else. There's no sheet underneath, you just pick up the patient and move them. Just pick those up and move them. Right. As far as the extremity lift, called the extremity lift or extremity carry, usually known as the GS carry, stands for Georgia Street. Apparently that is a bar, like it's in New Orleans or something, or street rather, where all the bars are in New Orleans. So they'd use this to carry drunk people.
You know what I have done this before?
No.
Yeah, let's
What's that?
I said I have done this before.
Yeah, probably. Right. Now, we're going to show you guys how to do this tomorrow as well. But with this, it tells me they're probably going to be moving quite far based on how she is grabbing the patient. Okay, usually we just go from a seated position to a seated position. So it's pretty straightforward. We usually grab from the sides as we move the patient from a lateral position to another one. Okay, again, strong person should be at the torso. And there's a lot of different ways you can grab onto the patient at the torso. Again, we'll show you our preferred methods tomorrow for whoever's teaching that station. I don't know if I'll be doing it or if Andrew's going to do it. But we'll go ahead and move our patient over. As far as getting them out of there, if it's unsafe, okay, again, we get one shot to pull that patient out to safety with us if the scene becomes unsafe. Okay, so if they're pinned in something, we have to try to do rapid extrication, aka yoink, yoink. All right, where we go ahead and take them out of there. So, some examples of emergency moves. Okay, it's going to be the arm drag. We just grab them by the arms and just pull them out. Okay, we're going to show you guys how to do a blanket drag tomorrow, where we go ahead and roll the patient onto a blanket, wrap them up like a little burrito, and then drag them out that way. Okay, if we don't have time for that, we can do the clothes drag. We just grab them by their clothes and just pull.
That's some shit my mom
Right.
at the grocery store.
Or,
Grandma.
didn't do enough of it apparently. Right, or the arm to arm drag. Okay, we go underneath, looks like a Georgia Street or extremity lift, and then use that to drag that patient out. Okay, now these are again emergency situations, so we have to get out of there because the scene's not safe. Okay, now depending on the situation too, if there is a fire, okay, if we happen to be there for whatever reason, okay, we want to make sure we're staying nice and low, right? That way we don't get caught in that thermal layer, get burns, inhalation of smoke or toxic gases, all that kind of stuff. So, there's different types of moves. Okay, so we have the front cradle, if you want to look all heroic. Okay, we go ahead and pick them up and carry them out. Okay, there's the firefighter drag.
Yeah, I've seen that.
Right?
It's where you tie their hands around the neck so that they can't
Yeah.
move and you pull them with your body to crawling.
Yeah,
It's
staying
so
low.
Yeah, it's how you miss the thermal layer. Oh.
Yeah. All right, so we can move patients out that way.
That's not
All right, only if it's indicated. Okay, we're not gonna do it. Oh, we got all this room for activities.
I didn't get time to go to the gym, so just.
Yeah.
What the heck?
Bro.
The one person walking assist. I know. All right, so we got the one person walking assist where you just pretty much
That's when you can divert.
throw the arm over.
That's dope as
Yeah.
hell.
And-
The whole last piggyback ride, she's docking his neck.
The elbow dislocator, right? We throw 'em over.
More like she's gonna
Okay.
suffocate, bro.
The
Like,
first one is we get at Bernie's.
Yeah, that
Yeah.
doesn't look like it feels.
So we'll go ahead and use that if we have to. But again, there's a lot of other more efficient, less painful ways to treat patients.
That was yeah, the
Yeah.
pack that back.
Okay.
That one's good.
That's the go.
Yeah. So we got that. If we need to move them out of there,
That's
again,
what
looking
you call
all
last.
super extra heroic if you have to.
Boom.
All right. So as far as rapid extrication, again, we're going to do this if the scene is unsafe or the patient is
Unstable.
unstable. Okay, where we get one shot to try to pull them out. Okay. So here we're going to just put the backboard at a 90-degree angle, and we do something similar with the CAD, and we just drag them out onto that backboard.
Who's this person in civilian clothes? Got like backboard just on hand. Like,
You don't have one in your pocket.
Prepared. He's like,
Just gonna fold
oh
the
my
backboard.
god, unstable.
Exactly. Just happened to be one right
Good thing I
there.
have my gurney in my
Good thing my
car.
pockets are bigger on the inside.
No.
So,
Hell no.
we'll go ahead and just drag them out, get them secured, and then we just move the patient from there. All right, doing whatever assessment and treatments need to be done. So, rapid extrication, right, is done if the patient is
Unsafe
What the scene is
unsafe.
One
unsafe.
shot. Unsafe. Unsafe.
What?
Or if they're blocking,
The unstable patient.
all right, blocking an unstable patient. Okay, then we go, sorry, lady, yoink, and then we get access to the other patient and yoink, and
We
we
say
get them out.
Because we do it.
What's up?
We say yoink. Like,
Yeah, I'm
does that
totally gonna
help?
say that. I'm totally gonna
Yeah.
say that. There's no way you're not gonna catch me. Yoink, next person.
All right, so, right, it requires knowledgeable EMT, so I don't know if you'll actually get to the point of saying that.
Through time
So-
and effort, dedication.
You gotta take the class one more time.
Yeah.
So we'll go ahead and move these patients out, right? Try to get them to safety. Now, if you have a patient who's unconscious, you got to get them out from the driver's compartment. Okay, make sure the feet aren't tangled up in the pedals. So free them, and then rotate that patient 90 degrees, grab from under the armpits, and then just drag them out. Right? And we can drag them out to an area that's more safe.
Do we get a test of some people tomorrow? Like actually do this on our
No.
friends?
You guys are
I
only
do
doing
this
extremity carries and
later
flutter
tonight.
drags. That's it.
Later tonight.
That's
Whatever you
okay.
guys do outside on the street is
That was scary.
Right.
Yeah, good.
Yeah.
So,
just-
as far as
I got that
decontamination,
Mhm.
okay, so again, decontamination is the
Oh.
process of properly removing and disposing of
Waste.
hazmat. Okay,
Hazardous
right?
materials.
Hazmat, whereas disinfection is the process of killing pathogenic agents with chemicals
Specific.
designed to do that.
Yeah.
Okay,
Right.
so that is the difference there, right? So, as far as different types of positions, right, and things like that, obviously those who have respiratory issues, keep them up in the
Fowler's.
position. Okay, we got a pregnant lady who's in late stages of pregnancy. What position do you want her in?
Left lateral.
Left lateral. Okay, we got a patient who's got a spinal injury. What position do you want them in?
Supine.
Supine, right? So again, we want to make sure you're putting them in the right position after you move them, whichever way is needed. For restraints, Okay, can we restrain anybody?
No.
No.
Okay, we have to do it on a 5150, and can we authorize those?
No.
Who can?
Docs and cops.
Okay.
Cops, you said?
Yes, that's exactly what I said.
Sure. So, all right, law enforcement, all right, and doctors, okay, they can go ahead and do that. And once we have the patient restrained, what do you got to document?
CMS.
And every
5 minutes.
Right. Okay, so as far as questions to ask yourselves when you move the patient, first off, can I actually move this patient?
Always. Yes.
Okay, just depends.
Manifested.
Okay, you need to make sure that you go ahead and actually move your patient. Not only do you have to worry about you not hurting yourself, but you also have to make sure you don't hurt who else?
Patient.
Besides the patient, yes, your partner. Okay? Because usually, right, you are going to know your limits, your partner knows their limits, but they may not know what your limits are and then cause you to get injured. Okay? So you need to make sure that you are coordinating and communicating with your partners. Okay? Because they cannot tell you how many times, right, people get hurt, not because of themselves, but because of their partner. Okay? And again, you should not go in there thinking about yourself, right, in this case, but be considerate of your partner as well. Okay? So, we got to make sure we have enough room to actually move the patient. Okay, so do we have to drag them out to another place where I can actually get enough space to bring my butt down all the way to lift them up? Okay, and do we need additional help? Okay, do we have to call for a lift assist? Right? So, just make sure that if you're injured, you obviously can't do anything else because you're now a what?
Patient.
You're now a patient, or at the very least, you're out of service. Okay.
What's an adrenaline shot for?
No way.
Hit yourself real quick.
Smelling salts.
Let's go!
All right.
Yeah.
So
Oh, yeah.
that's it. No
That's
new
it?
lectures.
Oh.
Come on, man. You know your guys are questions. Like,
No, not because we still have 2 more days of lecture. Okay. We got your medical review on Monday. We got your trauma review on Tuesday. Okay. And it's I who will be asking the questions.
aw.
Okay.
Can I ask a question to your question?
Yeah.
It becomes Socratic method now.
What's up?
Socratic method.
He's about to
Yeah,
drill us.
maybe. Okay, so as far as next week, as Matt was saying, right, Monday's medical review, Tuesday's trauma review, Wednesday's skills review. A week from tonight is your written exam. A week from tomorrow, all right, is your skills exam.
Okay, now here's my question.
What?
I'm confident in my skills as an EMT. Are you confident in
And
my
your skills? We'll find out tomorrow.
Oh, shit.
No, I mean like my knowledge as well. Do you think?
No.
are you- no? Damn.
Could we know what's like the written exam and
Yeah, can you
the
tell us what's gonna be on like
practical exam? Like what is the process of it?
Yeah, you come in here and you get tested.
Sick.
Well, can you tell us
What-
what's on the question?
Is it like a is it like
Yeah,
a
all the stuff you learned in class.
free response?
No, they're multiple choice.
Oh,
Oh,
okay.
thank
Yeah.
the Lord.
Yeah, 'cause you guys-
And this is the skills test, like scenario based.
You'll find out.
Okay, so yeah, it is all multiple choice, correct?
Yes, your written exam is multiple choice because national registry is also multiple choice.
Oh, thank the Lord.
Okay.
I can't spell for shit. I failed.
So,
Real.
really quick before I forget.
My phone's not been charging. I am. Damn. I tried to have my phone for a while.
You didn't check your list yet?
I did. Yeah?
It's gonna be like that.
You give her on the bottom.
I'm sorry.
Funny?
I would laugh.
Wait, no,
Then I would apologize afterwards for throwing that. Like, no one's
I don't want any business with that.
No, that should be thrown in no girl's face without.
We gotta come before class?
Yeah.
With consent? Yeah.
All right. As far as Saturday, gonna have you guys sign up tonight. You can sign up tomorrow if you need to as well. So you don't have to go ahead and do it right away. Just need first name, last name, phone number. Okay. If you guys are putting your name on this front part of the paper, you're committing to your time, right? That you're actually going to show up. If you're not quite sure yet, just put your name on the back, and that's fine. Okay. Again, you don't have to do it right this very second, but you can do it tomorrow as well if you need it.
money on
Okay.
So,
So
payment, can it be cash?
cash or Venmo, either one. All right. So that's that, and then tomorrow, okay, again, we're going to be going over the rest of you guys' skills, and then once you get back from dinner break, you're not learning anything new for the duration of your course. Okay, so we're going to go over no complication childbirth, going to go over your meds, right, and lifting, dragging, as well as special spinal.
Lifting, dragging.
Okay, so see you tomorrow.